signals and actions of fever are same. That means there is a scientific basis which is common for all these diseases related with the fever and it can be used to explain the secret of all disease related with the fever. This is the table Jacob's equation of separating fever, hyperthermia, and disease. Fever equal to fever condition minus disease, lack of fever. Another the disease lack of fever equal to fever condition minus fever. Fever condition equal to disease lack of fever plus fever. Artificially increased hypothermia equal to uncontrolled temperature like hyperthermia condition minus disease lack of hypothermia. Disease lack of hypothermia equal to hyperthermia condition minus artificially increased hypothermia. Hypothermia condition equal to disease lack of hypothermia plus artificially increased hypothermia. Another table, Jacob's table showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. Symptoms of fever: bitter taste, body pain, fatigue to mind and body, reduced appetite, reduced motion and indigestion, and aversion towards cold substances, internal external discomfort, etc. Signals of fever. Below that you can see the signals of fever. Below that you can see the signs of fever. Actions of fever also you can see. The middle part of the symptoms of rising temperature. Below that is signals of rising temperature. Below that the signs of rising temperature. Below that actions of rising temperature. Right side of the table, symptoms of disease, signals of disease. Below that is signs of disease and actions of disease. Okay. Next, let us examine the present state of fever. One medical book says our understanding of the neural basis of thermoregulation and fever is still rudimentary. The role of fever in defense reaction is not clear. Our first question is, how can fever be treated with rudimentary knowledge? The fact that the patient does not know that the fever is being treated by rudimentary knowledge is the basis for the survival of the physician. A scientific approach is necessary to evaluate and treat fever. My research is to find out the purpose of rise of temperature in the case of fever. Different types of fever definitions can be seen in various medical books. The following 8 questions need to be answered to know about a fever. First question is, what are the ingredients necessary to develop a fever and hyperthermia? Second question is, what are the ingredients necessary to curing fever and hypothermia? Third question is, what is the purpose of temperature of fever? Fourth question is, why is the temperature of fever not above 42 degrees Celsius? Fifth question is, the heat energy used for which activities in a fever and hyperthermia? Sixth question is, what are the problems not knowing the purpose of fever? Seventh question is, what are the differences between actual fever and temperature of fever? Eighth question is, during fever, why our body acts against effects of disease? No medical books give a clear answer to above 8 questions. Necessary ingredients to develop a fever and hyperthermia. Modern science says that fever is an inflammatory response that extends beyond the site of infection. The right ratio ingredients like inflammation and pyrogen is necessary to develop a fever. Like a good health, inflammation and pyrogen never cause hyperthermia. All that is needed for hyperthermia is uncontrolled heat only. Many people who have infections in the body do not develop a fever. Many people who have diseased organs may not develop fever. This is lack of right ratio to development of fever. Necessary ingredients to cure fever and hyperthermia. For curing fever, 1 second. For curing fever, we should know what are the ingredients necessary to develop a fever. Displays the correct ratio ingredients of fever will decrease the intensity of fever. By removing correct ratio ingredients of fever will cure the fever. If the inflammation is reduced, the fever will go away. The only way to change hypothermia is to water and reduce the heat. Hyperthermia does not go away because the inflammation is reduced like a fever. What is the purpose of temperature of fever in COVID-19? When the disease made by SARS-CoV virus 2 becomes a threat to life or organs, blood circulation decreases. The temperature of fever will emerge to increase, providing essential blood circulation, and it acts as a protective covering of the body to sustain life. It is an adaptation. In all diseases which decrease essential blood circulation and temperature, fever will emerge to increase essential blood circulation and temperature. There is no way other than this to increase prevailing essential blood circulation for a sensible and discrete immune system to protect the life or organ. Modern science says fever is immune response against infection. If there is immune response against infection, temperature of fever is not a surface temperature. It is not supposed to be eliminated from the body. If you try to eliminate the immune response against infection, the infection will increase. It is dangerous to immune system. It is necessary to protect immune system. To increase essential blood circulation, never allow body temperature to lose via atmosphere. A brooding hen's body temperature increase like that. During a fever to increase essential blood circulation in the body, the brooding hen does not eat any food. Brooding hen's food is its heat, which help to convert fat into energy. Many people who have misconception that fever should be cured or changed. It is not the fever that need to be cured or changed. It is the disease or cause of disease that need to be cured only. Fever is an adaptation only. Fever can be compared to our soldiers. Sometimes our patriotic soldiers may be defeated, surrendered, or even die. It is not due to the anti-national activity of our soldiers. New fever definition. If essential blood circulation decreases to the organs, fever is a sensible and discrete action of immune system to increase essential blood circulation as a self-defense mechanism of the body to sustain the life or organ. We can answer almost all the questions about the fever with this definition. If we avoid or evade from this definition, we will never get proper answer to even a single question. Why is the temperature of fever not above 42 degrees Celsius? To know the answer to this question, you need to know what the temperature of fever is for. When our body is over 42 degrees Celsius, our immune system knows that vitamins, proteins, and other elements will lose their proper form and perish, and need up to 42 degrees Celsius to save life and organs until the last minute. So our immune system creates temperatures below 42 degrees Celsius. When the hen is brooding, the temperature of hen does not exceed the limit because hen's immune system produces heat with a clear purpose. Once that purpose is accomplished, that increased heat will disappear or the production of that extra heat will stop. Similarly, our immune system created temperature below 42 degrees with the clear intention of saving life or organ until the last moment. Once that is accomplished, our immune system will stop overheating. The temperature of fever increases in proportion to the increase in inflammation in our body and the decrease in blood circulation. Inflammation is a condition which the temperature of fever increases as the blood circulation decreases. Similarly, as the inflammation decreases and the blood circulation increases, the temperature of the fever decreases. The heat energy used for which activities in fever and hyperthermia? Increased blood circulation to most important organs. In disease increase of fever, the activity of most important organs increases and the activity of less important organs decreases. This is not due to the increase in temperature, it is due to the decrease in essential blood circulation. This is like an inverter used to work most essential lights and machines in an emergency due to power failure. During fever, our body increases activities of most essential organs like brain, heart, kidney, and liver. Uncontrolled temperature can occur in heat stroke. it is not below 42 degrees. Moreover, it was not created for specific purpose. When our immune system does not, when our immune system does things like water sponging that reduce the temperature of fever, the body resists and hates it. The body never likes the temperature or heat stroke, and the body likes all the activities like sponging with the water that reduce the temperature. When there is a fever, the body like and upset the temperature up to 42 degrees from outside and inside to the body. Similarly, the truth can be identified by examining the body's aversion towards the temperature above 24 degrees when there is no fever. Why do fever have symptoms, signs, signals, and actions? Fever is an action that has symptoms, signs, signals, and actions, keeping the temperature below 42 degrees Celsius is just an act of fever. Another action of fever is the action of TNF alpha, a chemical that causes bitter taste and decreased appetite. Why does not everyone with the reason have a fever? Three reasons. First reason is virus, bacteria, and fungi does not cause fever in everyone because the cause of disease does not decrease essential blood circulation to the organs. Second point is the body does not need fever production. Third one is the immune system does not have energy to produce the temperature of fever as in AIDS. How can create fever and hyperpyresia and fits within hours? In people with tonsillitis and children, and elderly using ice water, we can create a fever and hyperpyresia within a few hours. With the continued use, we can cause death in them. Talayukutal is the best example. Talayukutal. Talayukutal is the traditional practice of sanicide, killing of the elderly, or involuntary euthanasia by their own family members observed in some parts of southern districts of Tamil Nadu, state of India. This is a process in which an extensive bath is given to an elderly person before the crack of dawn. He or she is given several glasses of cold, tender coconut water and head massage with cold water. By doing this, temperature of body falls suddenly and causing high fever, which leads to the death of old age person within 1 or 2 days. Similarly, in COVID patients, using sponging with ice water, we can create fever and hyperpyresia within few hours. With the continued use, we can cause death in them. Prolonged exposure to water can cause fever. How unscientific is it to say that you can change that fever by dipping water in your body? That is another question. Some thought-provoking questions and answers. If pouring cold water on the body can reduce body heat and cause fever, hyperpyresia in Talutal, cannot any disease cause fever and hyperpyresia by pouring water on the body? The answer is can. Second point is, second question is there any difference between a fever caused by Talekutal and other diseases? The answer is no. Third question is there any difference between fever, fits, and death due to heat loss in Talekutal and a fever, fits, and death due to heat loss in COVID-19? The answer is no. Next question is there any difference between COVID-19 fever treatment and the Talekutal fever treatment and any other fever treatment? The answer is no. Fifth question is conservative fever treatment suitable to Talekutal? The answer is no. Sixth question is, in Talagutal, what are the necessary ingredients to cure hyperpyresia? Answer, to increase blood circulation and to decrease inflammation, heat supplementation is necessary and prevent the heat loss from the body. Seventh question is, if fever with the Talagutal can be cured with the heat, can fever with any diseases not be cured with the heat? The answer is can. Eighth question is, if water in the body can reduce body temperature and cause fever, then water again can reduce temperature of the body and cause fits uh, and death. As in Talagutal, the modern fever treatment can be done by sponging or immersing the body in ice water. In hyperparesia, can it not cause fits and death by reducing the body temperature? The answer is can. And most medical books say that patients with the hyperparesia should be immediately immersed in ice water regardless of the cause of disease. And then the question is, according to this, in patients with hyperparesia due to thalavital, does immersion in ice water cause death? The answer is there will be death. 10th question is, isn't the signs of fever, fits and death in the thalavital the same as the signs of fever, fits and death in the other diseases? The answer is yes. Next question is, will assisting fever treatment reduce COVID death? The answer is no. Next question is, did any patient die without developing fever in COVID-19 and without heat reduction treatment for that fever? The answer is unlikely to occur. Current understanding, it is said that prolonged exposure to water can cause fever, and that fever can be cured by sponging it in water. Fever is measured with a thermometer, and hyperthermia is measured with the same thermometer. That is purely unscientific. The basic elements necessary for a scientific treatment is not provided in fever treatment. How can we prove that the temperature of fever is to increase essential blood circulation? That's another question. If we ask any type of question related to fever by assuming that the temperature of fever is to increase essential blood circulation, we will get a clear answer. If we avoid or evade from this definition, we will never get a proper answer to even a single question. If we do any type of treatment by assuming that the temperature of fever is to increase essential blood circulation, the body will upset. At the same time, body will resist whatever treatment to decrease blood circulation. Third point is, if we measure the heat energy used for which activities in fever, we will know the purpose of the temperature of fever. It is astonishing that modern science has not been able to examine what actions with the heat energy of fever despite its advanced development. No further evidence is required to prove the temperature of fever is to increase essential blood circulation. We can create fever and cure, we can create the fever and cure it again. One of the criteria for a scientific method is to reproduce. We can make a fever with cold water and cure the fever with the good heat. We can make him feverish again. Apart from this, what kind of evidence is needed to prove that the temperature of fever is to increase blood circulation? Let me know new parameters to prove the purpose of temperature of fever. We can prove that the temperature of fever is to increase essential blood circulation to that parameters. Fever is a protector or destroyer of brain cells. Will, sorry, will temperature of fever protect the brain cells by increasing essential blood circulation to the brain, or will it destroy brain cells? When disease increases, essential blood circulation and energy level also decreases. The vertical height between heart and brain is more than 1 feet. When disease becomes severe, ability to pump blood to the brain decreases. Then blood flow to the brain decreases and delirious or fits are formed. As a result of this, brain cells are damaged, so the patient might be paralyzed or may even die. Fever and delirium. Fainting or delirious or damage to the brain cells is not due to the increased temperature of fever. It is due to decrease in blood circulation to the brain. Without knowing the purpose of fever and without examining what actions were taken with the heat of fever, it is said that fits and delirious would happen due to increase in temperature of fever. Temperature below 42 degree never cause any harm to our body. During summer, in some parts of India, atmospheric temperature is more than 45 degree. If atmospheric temperature is below 42 degrees, as in hyperparesia, there is no such a history. One have been affected with the delirious or fits. A sauna temperature ranges from 160 to 200 degree Fahrenheit. In a steam bath, the person being 15 to 25 minutes. Why taking a normal steam bath? Temperature inside the bath is more than 50 degrees centigrade. There is no such a history. One had fainted or affected with the delirious or fits. During fever, if you take the steam bath, fits never happens. Blood circulation never decreases. Skin never shrinks as in fever. Signs of curing fits. Regain consciousness even before the temperature subsides. When a fainted patient lies on the floor, the vertical height between heart and brain decreases. So the blood circulation increases to the brain and surface is cured even before temperature subsides. Many people misunderstand that regained consciousness is due to reduction of temperature. Shivering is to increase blood circulation. Hyperparesia temperature is below 42 degrees centigrade. Only 4 degree increase in body temperature. If a 4 degree increase in temperature occurs, there is no history to show that shivering occurs. If disease increases, blood circulation decreases, shivering is to increase. Sorry, shivering is not due to increase in fever, but due to increase of disease, decrease of energy, immunity power, strength, essential blood circulation, etc. Shivering helps to increase heat, then essential blood circulation will increase. Fever and shivering are protective actions according to the aim and target of immune system. If the body produces excess amount of heat or energy or force or strength, the body will never shiver. During fever, one shivers due to a lack of enough temperature in shivering area. In other words, if a body have enough temperature to maintain its normal body temperature, it will not shiver. The decrease of essential temperature to sustain life is the cause of shivering. In fever condition, how much essential temperature is decreased in the body? Corresponding temperature is produced to generate counterbalance of the decreased essential temperature. Animal behavior advantage of instinct. Buffalo does not try to enter or lie in water, nor drink it during fever. Buffaloes manage body temperature by immersing their body in water and drink it. But when they are having fever, they do not try to enter the water nor drink it. Ways to eliminate fever by increasing blood circulation. 1 second. What happened? Okay. Sharing. Just listen to the messages from the body. Can you hear me? Hello? Hello?
Yes, sir.
Yes, yes. Just listen to the messages from the body and act accordingly. Accordingly. Increasing essential blood circulation is a right treatment for fever. Blood circulation never increases without increase in temperature, which can never be cured without increase in essential blood circulation. To increase essential blood circulation, never allow body temperature to lowest by atmosphere and apply extra heat from outside and inside to the body. It will help to immune system to fight against infection. Blanket, steam bath, hot sun bath, or thermal heat pad, hot pepper water, hot drinks can be used. Mechanism of application of heat. When temperature produced by the body due to fever and heat which we applied on the body combines together, the essential blood circulation increases. That immune system will stop to produce heat to increase essential blood circulation, and the body will get extra heat from outside without any usage of its energy. Heat is the fast and efficient remedy to reduce inflammation and increase blood circulation. During fever, 99% of disease or patient shows inflammation. Apply heat from outside and inside to the body. Blood circulation and inflammation-related fever and its signals, symptoms, signs, and actions will decrease. Then essential blood circulation increases, inflammation decreases, digestion increases, body weight diminishes. Like and abscess hotness. When we apply heat from outside and inside to the body, all the signals, symptoms of fever, like and upset to the hotness according to the directions and commands of immune system. If fever is immune response against infection, our body like and upset to hotness. At the same time, our body dislike and hate temperature reducing methods. If there is immune response against infection, temperature of fever is not a surface temperature. If you reduce temperature by water sponging, infection will increase and it may be dangerous. Fever is not a part of disease, it is a part of self-defense mechanism of the body and it is an adaptation. A disease does not require fever, but at the same time, a fever requires a disease. Both disease and fever are different. We cannot include both body distressing disease and body protecting fever in the same group. Conservative fever treatment and its effects. One, I already told about our understanding of the neural basis of thermoregulation fever is still rudimentary. How can fever be treated with rudimentary knowledge? Fever treatment, role of sponging and paracetamol. Whatever happens to a brooding hen and egg is sponged with water. The same happens to a fever patient if temperature is decreased by sponging. The same thing happens in Talaikotal. I already described what is Talaikotal. The researchers found that the glutathione level were lower when single dose of paracetamol was used. This may increase the inflammation level. Removing out temperature of fever by sponging of paracetamol is not helpful for curing disease. It is believed that the doctor will save the patient in the treatment of fever, but the doctor becomes the executioner who kills the person. All conservative treatment for fever not only do not make a radical cure of the feverish condition, but also further decreases the essential blood circulation and increase inflammation and leads the body to more dangers. The best way to reduce COVID death rate is to ban conservative fever treatment in the Talaikotal model. If temperature is decreased by sponging or paracetamol, disease or cause of disease or cause of fever is never decreased. That is a most important point. It is proved that fever medicines are more dangerous than disease, and fever treatments are more dangerous than medicines for fever. A lot of problems emerges not knowing the purpose of temperature of fever. It may cause death. Various hypotheses, contracted definitions, contractory fever treatments, etc. are the result of not knowing the purpose of temperature of fever. Contractory fever treatments, various types of sponging. Some physicians recommend sponging with hot water. Some physicians recommend with normal water. Some physicians recommend with ice water. Most medical books say that patients with hyperparesthesia should be immediately immersed in ice water, regardless of the cause of disease. If patient is shivering, all patients recommend hot water sponging. Most patients trouble when they have hyperparesthesia. If if the temperature of fever is surface temperature, or it is supposed to be eliminated from the body, the ice water must to reduce body temperature. If fever is immune response against infection, never use temperature reducing methods like sponging. Use of ice water is a modern version of Talaikotal. If fever is body's own disease fighting mechanism, how does various types of water happen to doing it? Another contractory fever definitions can be seen in various medical books. Fever disrupts homeostasis, body own disease fighting arsenal, beneficial effects of fever, the adverse effects of fever, fever increase immunity power, fever decrease immunity, all are seen in various medical books. If fever disrupts homeostasis, fever is always dangerous. So it is eliminated from the body. If fever is immune response against infection or body's own disease fighting arsenal or fever increase immunity power, it is always good to the body. Another contractory fever treatments, cool air. Some physicians instruct to use cool air, or fan or air conditioner. Some physicians prohibit to use air conditioner or fan. Everyone in the ICU use air conditioner. If temperature of fever is surface temperature or it is supposed to be eliminated from the body, air conditioning is must to reduce body temperature. If fever is immune response against infection, never use fan or air conditioner. Never allow body temperature to loss via atmosphere. Another contractory fever treatment is blankets. Some physicians instruct to use blankets. Some physicians prohibited from using blankets. If If the patient is shivering, all physicians will tell the patient to use blankets. If the temperature of fever is surface temperature, never use blankets. Blankets increase the body temperature. If fever is immune response against the infection, always use blankets. Another contradictory fever treatment is drinking water. Some physicians instruct to drink hot water. Some physicians recommend it to drink cold water. If the patient is shivering, all physicians recommend drinking hot water. Most patients tremble when they are having hyperpyrexia. If the temperature of fever is surface temperature, always use cold water or ice water. Never use hot water. It helps to increase the body temperature. If fever is immune response against infection, always use hot water. After analyzing and evaluating the above statements and correlating them, it becomes clear that what is right and what is wrong. Besides that, it was found that all the statements in medical books were contradictory, leading us to utter confusion. A science cannot have such a conflicting practices. If we read the contradictory definitions and treatments in front of a rock statue, it will start to blow. Is there any base to conservative fever treatment? No. All treatments for fever are based on the belief that the fever temperature between 38 to 41 degrees harmful to brain and body. At the same time, there no concrete evidence to this belief. Second point is the purpose of rise of temperature is not known. Without knowing the purpose of temperature of the fever and without examining what action was taken with the heat energy of the fever, what science can be used to say that the fever is dangerous? That is another question. Hitherto, the aim and target of rise of temperature in the case of fever has been subject to innumerable research by lot of medical universities of international repute. But unfortunately, the body medical scientists have concluded that the purpose of the rise of temperature could not be found. The importance of the finding of the purpose of temperature of fever in COVID-19, immediate relief from fever and body pain, life-saving discovery, a single magic answer to every fever-related question. If medicines are prepared according to the purpose of temperature of fever, any country can guide the world in the cure for fever. Conclusion. When disease becomes threat to life or organs, the temperature of fever in COVID-19 is to increase essential blood circulation. Fits, delirious, or damage of brain cells are not caused when an increase in temperature of fever takes place. It is due to decrease in blood circulation to the brain. Apply extra heat from outside and inside to the body will increase blood circulation. We can make fever with cold water and use heat to increase blood flow and cure the fever. Pouring cold water can reduce the blood flow in the body and cause fever again. Conservative fever treatment should be revised according to the sensible and discrete action of immune system. There is only one way to reduce COVID. Prohibit the lethal model, conservative fever treatment. There is no way other than this. It is wonderful that a physician having years of experience in fever treatment cannot understand actual purpose of temperature of fever. I have developed 8 days affirmative cross-checking questions. It proves that fever is to increase essential blood circulation. In the case of fever, double-blind study and Facebook cannot be done properly because the patient will quickly recognize this when experimenting with heat instead of using conservative cold as a way to reduce the temperature of the fever. Please note that 9, 10, and 11 both are the three items 9, 10, and belong to the Tadayuta. Thank you hearing me patiently so far. I already shared the link of another paper, Fever is not a symptom in COVID-19, that is published in a journal. I already shared with the delegates. If you do not get that link, I will change. I will share. Any questions?
Any questions to Dr. Jacob Matai? If you have any questions or comments, you can text here in chat box so that we can ask ask behalf of you. And thank you,
Okay,
sir.
thank you.
Thank you very much,
Welcome.
sir. A nice presentation, and our on behalf of our OCM of Oncology Congress, we want to thank you for insight presentation, and looking forward to meet you in upcoming meetings.
Okay, I am ready. Welcome.
Thank you, sir. Thank you very much.
Thank you hearing me patiently so far.
Yes. And now we ask Dr. Haitham Aysam, King Abdulaziz Medical City, Saudi Arabia, to join this event and start keynote presentation. Please share your PPT, sir. Hello, sir. Hello, Dr. Haitham. Sounds are not good. Your voice is very low, I think. Please check your audio settings properly. Hello, Dr. Haitham. Your voice is not. ఏం పెట్టారు? Yes, sir. Start the presentation. Audio is not listening, sir. No, actually, your voice is very low, I think, maybe. Or no audio icon in your no icon is not it's not so, sir. Yes, okay. Can you speak loudly? Your voice is not here. And share your screen. Hello, doctor. Are you facing any technical problem? Are you facing? Hello, Dr. Haitam. Are you facing any technical problem? Meanwhile, go with other speaker. Any other speaker? If you have facing any problem, please text me in the chat box so that we can help you. Sure. Hello, sir. Meanwhile, go with any other speaker. Please reply me if you have any facing it, any technical issue. After you can check and after you can present next talk. If possible, you can present through mobile also, no problem. If in case facing laptop issue. Sure. Just a minute. Just a minute. Dr. Haitam is some technical problem. Is facing some technical problem. Now we invite Dr. Bhagyasri.
Yes, sir.
Kaitam Katihar Medical College, India. Title Obstetric sorry for that. A ray of hope for dying mother. It's one of the talk. So you can present, madam. You can start your presentation and share your PPT properly.
So it's written host disabled participant screen sharing.
Just a minute. Just a minute. Now we start.
So am I audible?
Yes, sir. Yes, madam. Yes, madam.
Yes. And my screen is visible, sir?
Yes, yes.
A very good afternoon to everyone. I'm Dr. Bhagyasri, final year MS student, departments of Obstetrics and Gynecology, Katihar Medical College, Katihar from India. My topic for presentation is obstetric hysterectomy, a ray of hope for dying mother. Emergency obstetric hysterectomy is the removal of uterus either after vaginal delivery or during cesarean section or during postpartum period. It is a vital procedure to save the life of a mother, opted as a desperate attempt when all the measures fail to control the catastrophic hemorrhage. Trying situation for the obstetrician, as on one hand, it is a life-saving procedure, but on the other hand, it puts an end to the women's reproductive capability. objective of this study was to know the incidence, risk factors, and maternal and fetal outcomes in cases of obstetric hysterectomy. Review of literature. Hysterectomy is most commonly performed to arrest or prevent hemorrhage from the intractable uterine atomy or abnormal placentations, stated by Batman, Hernandez, and Ovalabi. During a 25-year period, the rate of peripartum hysterectomy has risen, attributed to the increasing rates of caesarean delivery and its associated complications in subsequent pregnancies, stated by Baudillon and Flood. An important factor affecting the caesarean hysterectomy complication rate is whether the operation is performed electively or emergently. With anticipated or planned caesarean hysterectomy, rates of blood loss, blood transfusion, urinary tract complications are lower than that with the emergent procedures, stated by Bridie and Glaze. The methodology, this study was a hospital-based retrospective study, and the place was Katehar Medical College, Department of Obs and Gynae department, and the period was from January 2019 to December 2019. Result. Total deliveries during this period was 11,500. Out of this, 40 patients underwent obstetric hysterectomy and giving an incidence of 0.35%. Maximum patients belong to the age group of 26 to 30 years. Minimum age was 21 years and maximum age was 35 years. Majority of the patients who underwent obstetric hysterectomy were uneducated and unbooked. This is the table showing the incidence of emergency obstetric hysterectomy following vaginal delivery and cesarean section in the study done. So the total number of patients underwent vaginal delivery were 9,430. And out of them, 15 patients underwent emergency obstetric hysterectomy, giving an incidence of 0.15%. The total patients who underwent cesarean hysterectomy were 2,070, out of which 25 patients underwent emergency obstetric hysterectomy, giving the incidence of 1.21%. And so total 11,500 patients who delivered, 40 patients underwent emergency obstetric hysterectomy, giving overall incidence of 0.35. This is the graphical presentation showing the incidence of emergency obstetric hysterectomy following vaginal delivery and cesarean section in our study. As in this graph, we can see that the number of patients who underwent emergency obstetric hysterectomy were clearly greater than those who underwent vaginal delivery. The indications and high-risk factors. So the total number of patients who underwent emergency hysterectomy in our study were 40, out of which 22 patients were because of postpartum hemorrhage, under which 14 were because of atonic PPH and 8 were major degree of placenta previa. 10 patients were from the ruptured uterus. The reasons for the ruptured uterus were obstructed labor was noted in 6 patients, prolonged labor was noted in 2 patients, and oxytocin misuse was noted in 2 patients. 8 patients with previous LSCS with morbidly adherent placenta also underwent emergency obstetric hysterectomy. So out of 40 patients, singleton pregnancy were 38 and twin pregnancy were 2. This is the graphical representation showing the indications and high-risk factors. As in this, we can see that the maximum number of patients in our study who underwent emergency obstetric hysterectomy belonged to the atonic PPH group, that is 14. The placenta previa group is 8. Previous LSCS with morbidly adherent placenta were 8. Obstructed labor were 6, and other cases. This is the picture showing a case of ruptured uterus. This patient underwent emergency obstetric hysterectomy because of intractable hemorrhage. This is this specimen after the subtotal hysterectomy in the same patient of the ruptured uterus who underwent emergency obstetric hysterectomy. This is the table showing the obstetric hysterectomy in different age groups and parity. So in our study, we distributed the patient according to the age group. So in the age group of 21 to 25, the maximum patients, parity 1 were 1, parity 2 were 1, age group 31 to 35, the parity 1 patient was 1, parity 2 was 1, parity 3 were 4, parity 4 were 2, and more than equal to 5 parity were 2. So total patients were 40, and this is the distribution according to the parity as we are seeing in different age groups. This is the graphical representation showing the obstetric hysterectomy in different age groups. And clearly we can see that the maximum number of patients who underwent obstetric hysterectomy belongs to a higher age group of 26 to 30 years. And the second number was 31 to 35 years. And the least number were noted in the age group of 21 to 25 years in our study. This is the graphical representation of the parity distribution of women included in our study. And as we see that the maximum number of patients who underwent emergency obstetric hysterectomy were in increased parity. This is the table showing the fetal outcome in our study, the patients who underwent emergency obstetric hysterectomy. So the total number of fetus were 42, as 38 were singleton and 2 were twin pregnancy. So the live birth were 10 in number owing to the percentage of 24%. Intrauterine death was noted in 18 fetuses owing to the percentage of 43%, and neonatal death was noted in 14 cases, that is owing to the percentage of 33%. So as we can see from the fetal outcome that the patient who underwent emergency obstetric hysterectomy, maximum patients had bad fetal outcome of intrauterine death or neonatal death. This is the graphical presentation showing the fetal outcome. As we can see clearly that the maximum number of fetus were intrauterine death or neonatal death. This is the table showing the maternal outcome in those who underwent obstetric hysterectomy in our study. So the total number of patients were 40. So morbidity factor is noted here. Multiple patients needed blood transfusion. So out of 40, 25 patients who needed multiple transfusion owing to the percentage of 62.5%. 6 patients had febrile illness owing to the percentage of 15%. 4 patients had wound infection owing to the percentage of 10%. 3 patients had shock owing to the 7.5%. 1 patient each of coagulopathy and paralytic ileus were also noted in our study owing to the percentage of 2.5% each. This is the graphical presentation showing the maternal morbidity in our study. As we can see that the maximum number of patients needed multiple blood transfusion. So discussion, incidence in our study was 0.35%. So out of the patients who delivered, the incidence of patients underwent emergency obstetric hysterectomy was 0.35%, which is near to that reported from Juneja SK et al. Study of incidence 0.52%. In our study, the most common indication of emergency obstetric hysterectomy was atonic PPH, similar to Juneja SK et al. And Chawla J et al. Studies. Most of the patients who underwent emergency obstetric hysterectomy in our study were multiparas, 90%. Incidence of twin pregnancy, that is multiple, who underwent emergency obstetric hysterectomy was 5%. In our study, maximum number of cases needed blood transfusion, 62%. None of the mother who underwent emergency obstetric hysterectomy died in our study. And fetal outcome in maximum cases underwent obstetric hysterectomy were intrauterine fetal death, that is 43%. So the conclusion of my study is obstetric hysterectomy can save many maternal lives. So fast decision and excellent surgical skill is required. Thus, obstetric hysterectomy is a necessary evil in obstetrics. Although it curtails the future childbearing potential of a woman, but yet it saves the life of a mother, thus also called a ray of hope for the dying mother. This is the reference which was taken for my study.
Any questions?
Thank you.
Okay. Thank you, madam. Thank you for your valuable presentation. Any questions to Dr. Bhagyashree? Any questions? Thank you very much, madam, for presentation in this event.
Thank you.
On behalf of OCM of Gynecology Congress 2021, we want to thank you for insight presentation. And we will we're looking forward to meet you again in next time physical events or online events. Thank you, madam. Thank you. Nice presentation. And now we ask Dr. Haitham Al-Sam, King Abdulaziz Medical City, Saudi Arabia, to start keynote presentation.
Can you hear me now?
Yes, yes, sir. Please share your PPT, sir.
Okay, I'll try to share on.
Just a minute.
the
Just a
screen
minute.
now.
Just a minute, sir. Yes, we can. Hello, Dr. Haitham. Again, technical issue. Please check your connections properly, sir. Okay. Now we will have just 5 minutes break and join this event after the 5 minutes. Hello, Dr. Haitham Al-Sam. Please start your presentation. Please fast. Good, fast. Please check your audio and video settings properly. Hello. Hello, sir. Where are you? Voice వస్తుందా? Hello. 1 second. Meanwhile, go with other speaker, sir. Please check. Download. Please share your PPT. Okay. నాది రావట్లేదా? నాది రావట్లేదా? హలో. హలో. దానికి రాదు అసిస్టెంట్. Just a minute, madam. As Dr. Haitham is prepared some technical issues, so just wait for 5 minutes. 3 minutes. Meanwhile, can you go with other speaker? Okay. Just a minute. Dr. Haitham is already has shared the PPT. Just wait. Hello, doctor.
Yes, please. I am with you now. Yes.
Yes, yes, sir. Just you can play, sir. I will, if in case I'm moving slides, just play next. I will move. Just a minute. Okay.
Okay. Thank you very much. Thank you, Chairman, and thank you for everybody attending the. And I apologize for the technical issues that is happening. I'm going to talk about the pregnancy and coronary artery disease. Pregnancy and coronary artery disease is one of the difficult situation to handle. And I'm going to share with you one experience with one patient who presented to our emergency room with acute coronary disease while she was pregnant. And if we can move to next slide, please. Next. So it was a 45-year-old female, gravida 7 para 5 plus 1, 32 weeks of gestation, who presented to the emergency room with acute onset of severe central chest pain with radiation to the jaw and back. Her symptoms were associated with shortness of breath, nausea, and vomiting. She had no prior history of angina and was only taking multivitamins pills without any other prescribed medications. Next, please. She previously delivered via cesarean section due to severe preeclampsia. And the family history, she had, or it was significant for premature coronary artery disease and familial hyperlipidemia. Her father had a previous myocardial infarction and diagnosed with diabetes mellitus, and 2 of her siblings developed coronary artery disease. So it was a significant family history of coronary artery disease and hyperlipidemia. Next, please. On examination, she was conscious, alert, and vital signs were or showed hypotension. And Taki at the beginning was normal heart rate, respiratory rate was 20, air febrile saturation was okay at that stage. Next, please. Then the respiratory examination, the lungs were clear, and normal heart sounds, no murmur have been found. Neurologic examination was okay. Initially, CG revealed inferior posterior ST elevated myocardial infarct. Next. And the patient suddenly became hypotensive, and her latest vital signs were as follows. Heart rate was heart rate was 70, and blood pressure showed hypotensive. The echo revealed a normal LV function with the diastolic dimension of 5.5 centimeter. Overall LV function were mildly reduced, like 45 to 50%, and inferior and inferior lateral walls were severely hypokinetic. Next. RV also showed mild reduction in systolic function, and all her valves were normal, both morphologically and functionally. There was no evidence of pericardial effusion or aortic dissection. Next. So she was diagnosed with acute inferior posterior STEMI, and the case was discussed with the consultant interventional cardiologist, and she was planned to go for primary percutaneous coronary intervention. Next, please. Yeah, the obstetric team was involved, and obstetric assessment also. We did ultrasound, bedside, showed appropriate size for gestational age. The baby was around 34 weeks, encephalic presentation with normal amniotic fluid index and Doppler. Next. Laboratories were significant of high BNP and MB fraction. So they were like into supporting the diagnosis of acute MI. Next, please. So counseling risk and benefits of the produced results were discussed at length and depth with the patient and her husband, and they agreed to go ahead with the emergency life-saving cardiac procedure with a clear understanding that involves risk to the patient and the fetus. Next, please. Management: the patient was taken to the cardiac cath lab in the presence of cardiac anesthesia, obstetric anesthesia, high-risk obstetric and intervention cardiology teams on standby. Next, please. And then it was performed and found ectatic coronaries and plaque disease were observed. There was plaque disease only in her left main artery. Her left anterior descending artery had also plaque disease only. An early diagonal branch had 60 to 70% proximal disease. Next, please. So the right coronary artery was ectatic with 99% mild course lesion. Circumflex also was small and anomalous, originating from the proximal right coronary artery. And then a drug-eluting stent was placed in the right coronary artery, okay? And she was advised to start on dual antiplatelet therapy for 12 months, aspirin and Plavix. Next, please. She was kept in the ICU for like 24 hours under observation with fetal well-being assessment, taken twice per day using via Doppler and CTG. Next. Her hospital stay was uneventful. She was discharged on dual antiplatelet therapy, aspirin and clopidogrel and metoprolol and ranitidine. She was discharged home on the 5th day of her admission. Next, please. And then to plan her delivery, it was discussed during a multidisciplinary team, a patient conference involving interventional cardiology, cardiac surgeon, cardiac anesthesiologist, obstetric anesthesia specialist, and a maternal fetal medicine specialist. The patient was scheduled to be seen on a weekly basis in the clinic, including maternal assessment, cardiac and general maternal health, as well as fetal assessment. Delivery was scheduled at 37 weeks with tubal ligation under general anesthesia, monitored by cardiac anesthesia and obstetric anesthesia in the presence of intervention cardiologist and cardiac surgery with continuity of Plavix. And that was the challenge. So we try to manage in between, like we're stuck between putting the patient at risk of thrombosis by stopping the Plavix, or continue the Plavix and risk of hemorrhage. So we thought that the patient, her risk of death is more with thrombosis. Another MI will kill her, but the bleeding, we may manage to deal with it intraoperatively. Next, please. And then a departmental form was used to formulate the plan of care. Surgery went smoothly without any complication. Estimated blood loss was around 400 ml. We were ready with all ultrasonic intraoperatively. The patient was extubated in a good general.
Hello, sir. I think some technical problem, Dr. Haitham Alsum. Maybe he will join shortly. Just a minute. Hello, sir. I think Dr. Haitham Alsam is facing some technical issues. Maybe he will join shortly. So meanwhile, go with the other speaker. Thank you, sir. And next talk will be Dr. Adeline Uraike, Resident of Obstetrics and Gynecology Department, Asaduddin University, Indonesia. Join the event and start poster presentation.
Okay, good afternoon. Thank you for the opportunity. Let me introduce myself. I'm Eureka Adeline Chandra from Hasanuddin University, Indonesia. I'm a fourth year resident of Hasanuddin Department of Obstetrics and Gynecology. So I will start to share my screen. Sorry.
Yes, bottom of the page, share screen, madam.
Yes, but I don't participate. I cannot. I cannot share my screen. Sorry.
You cannot?
Yes.
Just bottom of the screen, click the share screen button.
Ready.
Okay?
Yes.
Yes, yes. Fine.
So, here's my case report. Yes, undiagnosed and term abdominal pregnancy with healthy newborn. So, as we know, abdominal pregnancy is a rare type of ectopic pregnancy with estimated incidence of 1 in 10,000 until 25,000 live births. So, the maternal mortality may range about 0.5 to 18. It's quite higher, high rate of maternal and perinatal mortality. So, clinical diagnosis and ultrasound can be difficult in the near term or in advanced stage of gestation, and we can find a lot of case with congenital malformation such as Lyme and joint abnormalities, also the formation of craniofacial malformation. So the term abdominal pregnancy with healthy newborn is a rare case. And 40 years old woman, gravid 6, para 4, abortus 1, presented at 38 weeks, 3 days gestation. No abdominal pain and vaginal bleeding. She referred to our hospital with complete placental previa to terminate the pregnancy due to they didn't have a blood transfusion unit in that area. So on arrival, her vital was normal. No contraction was palpable. Fetal heart rate was normal, and in the speculum examination revealed a closed cervix with no mucus and blood discharge. We did ultrasonography and showed a live fetus in cephalic presentation with estimated fetal weight 2.8 kilograms with as we can see one, and see here is the fetal head, and this is the part of the placenta which is attached to the posterior of the uterus, and here is we can see the mass right here. This is we think it is the part of the placenta, but we cannot we just cannot just this is if it's the part of placenta, because we just did the Doppler ultrasound too. So a phaneum steel incision was made, and the amniotic membrane filled with clear core protrudes, and we the incision site. And after we incise the membrane, the fetus was delivered with cephalic and Apgar score 8.8 per 10 at the time with birth weight 2,700 grams. And at that time, we just found that the fetus was not intrauterine, and her uterus was found to be intact and no enlargement. Placenta was attached to the right fallopian tube, right ovary, and broad ligament, and ascending colon and omentum, as we can see in the figure 2. So when the placental bed is dissected and we ligated the omentum, we did omentectomy at the time, and we ligated and we dissected the placenta part from the colon, ascending colon, and the posterior wall of the uterus. But there is some small part of the placenta attached to ascending colon was left in situ to prevent the injury. And we did left fallopian tube in the right ovarian. We did right salpingo-oophorectomy, and the left fallopian tube. We did tubectomy with using Pomeroy modification. And after that, we insert Derivac drain to observe the bleeding. And after being observed in ICU for 2 days, the vitals were stable, drain output was minimal, and urine output was normal, and the patient moved towards, and she was discharged from the hospital on post-operation day 5, and her baby didn't need any respiratory support and did well until now. So advanced abdominal pregnancy refers to a pregnancy that continues beyond the 20 weeks gestation with a fetus living and showing sign of having once lived and developed in the mother abdominal cavity. In primary advanced abdominal pregnancy, implantation of the conceptus into the abdominal cavity, whereas secondary abdominal advanced pregnancy could be due to the familial abortion, tubal rupture, and rupture of uterus, and rupture of corneal pregnancy too. In this case, it's obviously that we found that the abdominal implantation was secondary, as we found the right fallopian tube was hypertrophy and anamnesis of the patient, he has no complaint of the abdominal pain in the early pregnancy. So diagnostic criteria of abdominal pregnancy by ultrasound may include demonstration of a fetus in gestational sac or state of uterus in normal, but the depiction of abdominal or pelvic mass identifiable as the uterus separate with ultrasound. We found that uterus separate from the fetus and local set of the placenta outside the uterine cavity. But in this case, we difficult to tell where is the uterus, because it is the advanced abdominal pregnancy, and the baby is already big, and it's difficult for us to diagnose. So a diagnosis of intrauterine of abdominal pregnancy is frequently missed, and with only 45% diagnosed during the antenatal period, and the rest are diagnosed during the surgery. So we conclude this case with abdominal pregnancy is a rare form of ectopic pregnancy with very high morbidity and mortality for both mother and the fetus in advanced gestation. And the importance of antenatal care and ultrasonography in the first trimester is a abdominal pregnancy. And also availability of blood products and cooperative with anesthesia team for potential massive blood transfusion and immediate detection and rapid surgical repair help to minimize the complication of the abdominal pregnancy. Thank you.
Thank you. Any questions to Dr. Adeline Urake? Any questions? Thank you very much, madam, for participation in this event. And on behalf of our OCM of Oncology Congress 2021, we want to thank you for insight presentation, and we will looking forward to meet you again in next time, and physical events also. Everyone goes well. Everything will goes well. Thank you very much. And next presentation, Dr. Priyanka Bagdi, Junior Resident, Sri Balaji Medical College, India, to join this event and start presentation.
Is my screen visible?
Yes, madam.
Okay, I'll just begin. Good afternoon, everybody. My topic is effect of the xylitol chewing gum on the postoperative recovery of intestinal motility after a cesarean section. I'm Dr. Priyanka Bagde. I'm a junior resident in the Department of Obstetrics and Gynecology in Sri Balaji Medical College, India. I have done my undergraduate from Sri Ramchandra University. I've published a couple of case reports on endometriosis, award-winning poster on his club ticks 2, that is male infertility. My vision is to provide with treatment to the needy in the remote areas of my country. I want you to introduce you to my topic, which is of chewing gum, which is a very basic thing that we started in our hospital. It is in cesarean section is the most common obstetric abdominal surgery due to active management of labor to reduce the maternal and perinatal mortality. We all know about Robson's criteria. Oral food intake is forbidden for longer time as it's in an open surgery, mostly resulting in ileus, which was shared with us with Dr. Bhagyashree, who had presented earlier, saying that post-operative ileus was common in her post-cesarean patients. Hence, which is very common over here also, and hence prolonging the length of hospital stay and increase in financial burden. The use of chewing gum to stimulate bowel movement has been reported in several randomized clinical trials in patients following a cesarean delivery. The result of some previous meta-analysis reviews in patients undergoing GI surgeries have shown that chewing gum fastens the bowel movement and shortens the length of hospital stay. The aim and objective of this study was to study the effect of a xylitol chewing gum in prevention of post-operative ileus, to enhance the post-operative recovery, to improve the food intake earlier, establishing lactation earlier, early establishment of GI motility in passing fetus, bowel movements, and all of this together helps in reducing the stay in the hospital. And especially now when the COVID is peak in India, we would want to admit our patients earlier and discharge them even faster. The methodology here is the study design was a cross-section study with a structured questionnaire. 100 post-operative women were selected after a cesarean section. The study area was the post-operative ward in Sri Balaji Medical College. Data collection instrument was a socio-demographic proforma. The inclusion criteria were all the pregnant women delivering with elective and emergency cesarean section in our hospital, which were aged between the age of 18 and 40 years. The exclusion criteria was, of course, patients who were not willing to enroll for the study and the patient delivering normal vaginal delivery. The study period was between the year January, between the months of Jan to April in the year 2021. This is how we had split it up the women. We had chosen about 109 women, enrolled them. 9 of them had backed up, reasons not willing, and further reasons unknown. And the 100 women that we had were randomized, and they were allocated into the case group and the control group. Basically, a group where we were giving chewing gum and in a group where we weren't giving the chewing gum in the regular post-operative care. And then we analyzed both the groups, and there were none lost to follow-up as we were monitoring them in our post-operative ward. Both elective and emergency cesarean sections were taken. Women who had undergone only cesarean section under spinal anesthesia, for the only reason general anesthesia can cause delay in gastric motility. In our study, we used a sugar-free flavored standard chewing gum, that's Orbit. Orbit is quite available very easily in our country, so we chose that, and it was sugar-free. Chewing gum was administered 6 hours after the surgery in our study. Compliance of the patient in post-operative period needed to be considered in that case. Our women were asked to chew the gum thrice a day till they pass or we get to hear the early bowel movement. There is no clear standardization regarding the time at which the chewing gum should be given to the patient in the post-op ward. One study has also shown a xylitol ingredient in sugar-free gum is associated with early recovery of bowel function and thus may be superior to the non-xylitol gum. And the results are here. The variables of age where we had seen both group A and group B. Group A including the one whom we had given the chewing gum, and group B was the group which we hadn't given any intervention and given the regular post-operative care that we have been providing since ages. And we had found that none of the p-value was significant in the age, as the age was very similar in both the groups. The BMI also was similar, where in the group A it was 26.05 plus or minus 2.83, and group B it was 25.74 plus or minus 2.10. The parity, that is primary group, belonged to 44% in group A and 52% in group B. Second gravida, that was 36% in group A and 42% in group B. Third gravida, 20% in group A and 6% in group B. Elective LSCS was done in 48% in group A and 48% in group B. And similarly, emergency cesarean were done in 52% in both the groups. The results, which were very shocking to all of us, was a woman felt hungry faster 6 hours earlier compared to a woman who was not given chewing gum, and hence the p-value was very significant. A woman felt her first hunger pangs at about 12 hours after surgery to the woman whom we had given chewing gum. They passed flatus 13 hours after the surgery, whereas a woman who were not given chewing gum would pass about after 15 and a half hours. The women who were giving chewing gum as a standard care passed motion, passed or stools at about 22 and a half hours after the surgery, whereas a woman who were not given passed motion only after 25 hours, more than 24 hours after the surgery. And the stay in hospital improved significantly, where a woman whom we had given chewing gum stayed about 5.5 days in the hospital. We could and a woman who didn't pass motion earlier had to stay about 7 days. And the side effects, the most common side effects that we would see is the nausea, vomiting, dizziness, and giddiness, which was not very significant in both the groups where we had given chewing gum as well as that we had not given chewing gum. Nausea was seen in about 5% of women whom we had given chewing gum, whereas 15% in the women whom we had not given chewing gum. Vomiting was seen in 6% of women whom we had given chewing gum and 2% in non-giving chewing gum. And dizziness was seen in 7% of the women, where was seen having dizziness. This is very common after certain hours of hypoglycemia. And giddiness was seen in 3% of the women whom we had given chewing gum and 10% of women whom we had not given the chewing gum. Now, why did we do this study? The reasons for delayed intestinal motility in immediate postnatal women is a very important topic which not a lot of us are aware of. It's because of the pregnancy hormones. Elevated levels of hormones such as progesterone contributes to the delay in gastric emptying. Gastric acidity is increased because of the higher production of gastrin by the placenta. And progesterone induces the inhibition of the mobilization of intracellular calcium within smooth muscle cells. And we all are very much aware that progesterone is a pregnancy hormone. These make post-operative ileus a common in post-cesarean section. Now, why was an intervention not thought before? Of course, people have tried multiple methods to reduce the post-operative ileus and enhance in the early gastric motility. Some people even encourage early ambulation. In some areas, we also practice early food intake or fastening the lactation enhancement. All these can help in early enhancing the post-operative recovery, which helps in reducing the stay in the hospital. Now, why the xylitol chewing gum? Xylitol is a natural sweetener coming from corn cobs and birch trees. It's a prebiotic. Prebiotics are compounds in food which help to stimulate the growth of healthy bacteria in the gut. It's a low glycemic index. It inhibits cavity-causing bacteria. Perfect sweetener, remineralize the tree and helps to relieve the dry mouth. Promotes oral health, helps to maintain clean and freshen the breath. This created a very nice thing that hence we had chosen a xylitol chewing gums. Now, although early oral intake has been promoted as a standard care after cesarean section, only one randomized control trial adopted the oral intake within 6 hours postpartum in both groups. Still, when early oral intake was standardized in each group, the gum chewing added more benefits in the intestinal function recovery. The duration of each chewing session was 30 minutes in our study, similar to a range of 15 to 60 minutes in other studies. The sugar ingredient in sugar-free gum, example the sorbitol and the xylitol. The xylitol may stimulate bowel motility and mobility and exert a laxative effect, yet the evidence on whether sugar substitutes in sugar-free gum. Result of this study demonstrate that there are no significant statistical differences between the chewing gum group and the control group regarding their personal characteristics such as sex, age, educational level, residence, and occupation. In our study, the mean time to hunger was approximately 6 hours earlier compared to the intervention group as compared to control group. This finding is comparable to other studies which have shown reduction in time for feeling hunger in post-cesarean patients ranging from 3 to 7 hours. There was no significant benefit in the time to first feeling of hunger in a meta-analysis of 10 randomized control trial, including 1659 women, possibly because of chewing causing a feeding feedback in the brain, and early feeding can accelerate hunger. It causes the effect of similar of that of a sham feeding. The mean time to first passage of flatus in our study was 2 to 3 hours earlier in the intervention group compared to the standard group, which was found to be lesser compared to the other studies where average time to passage of flatus was 6 to 7 hours shorter in the chewing gum group. The mean time to first passage of feces in our study was 5 hours early in the intervention group than standard group, which is 3 to 4 hours lesser when compared to other systemic reviews, which showed a 8 to 9 hour difference between the groups. The duration of hospital stay was found to be reduced by 1.5 days in the intervention group in our study, which is much earlier as compared to 0.3 to 0.39 days, that's about 8 hours, in the recent meta-analysis. 3 women did not chew the gum for the entire duration of 30 minutes, although they were instructed to do so. 4 women had to spit on the gum pellet intact at the end of 30 minutes. Another 5 women fell asleep during chewing as they were tired due to sedation. None of the patients had nausea, vomiting, requiring any kind of antiemetics, or did they have any other post-operative complications until discharge from the hospital. Conclusion, our study has found further supported that gum chewing is associated with early recovery of the intestinal function after cesarean section, which may be helpful to reduce the time to first passage of flatus, first defecation, first bowel sound, and first bowel movement, and hence shortening the length of stay at the hospital. Gum chewing offers a safe, simple, and inexpensive for hastening the recovery of the intestinal function after cesarean section, which is worthy of promotion for clinical use. Summary is handy, non-expensive, feeling of fresh. Once you pass flatus, once you pass feces, you definitely feel fresher. Eating earlier, prevention of halitosis, that's the bad breath. Intervention with an inexpensive and handy method was accepted happily by more than 90% of our postnatal mothers. These are my references. Thank you so much.
Thank you, madam. Any questions to Dr.
Any questions?
Priyanka Bagdi? Any questions? If any questions, please, any questions or comments, you can text here the comment box so that we can ask behalf of the participants. Thank you very much, madam, for participation in this event. And on behalf of our OCM of Gynecology Congress 2021, we want to thank you for insight presentation and looking forward to meet you our upcoming meetings.
Thank you so much.
Thank you, madam. Next talk will be, now we ask Dr. Shruti Shetty, Mahatma Gandhi Mission Hospital, India, to join the event and start presentation.
Good afternoon, everyone. Can you all hear me?
Yes, madam.
Good afternoon, everyone. My topic is HELP syndrome with acute kidney injury with COVID-19 infection. I am Dr. Shruti Shetty. I am a second year PG resident practicing in MGM Hospital, Colombo, India. Next slide, please. So HELP syndrome is characterized by hemolysis, elevated liver enzymes, and low platelet count. It is usually considered a variant of preeclampsia, but it can occur on its own or in association with preeclampsia. The disease is often associated with maternal complications like disseminated intravascular coagulation, myocardial ischemia, pulmonary edema, hemorrhagic stroke, acute renal failure, and neonatal complications such as prematurity and intrauterine growth retardation. Usually HELP syndrome sometimes is associated with elevated creatinine, which is also independent predictor of maternal mortality in HELP syndrome. AKI severely affects renal prognosis and is also an important cause of mortality in pregnant women. However, early diagnosis and treatment is required as termination of a pregnancy is must in such cases. Next slide, please. So I have a case report to share with you all, which is of a 34-year-old primary gravida with 34 weeks of pregnancy who was unregistered, came to NGM hospital with the complaint of epigastric pain and headache since morning. The patient was a registered case at a private hospital though and was on medications for, she was diagnosed as PIH, pregnancy-induced hypertension, and was on medication for the same, but she did not have a good follow-up at her hospital. On her examination, general condition was moderate, pulse was 94 per minute, blood pressure was 180 by 110 millimeters of mercury, icterus was present, pallor was present, bilateral pedal edema was present. Next slide, please. On systemic examination, for abdominal examination, uterus was 36 weeks size, longitudinal lie and cephalic presentation. Fetal heart sound was 100 per minute. Uterus was relaxed. For vaginal examination, showed cervix was 1 centimeter dilated, uneffaced, and patient was -3. So patient had a poor Bishop score. Next slide, please. So this patient was attended by us in casualty. We immediately put her on oxygen at 8 liters per minute. We gave her left lateral position. All lights around were turned off because she had signs and symptoms of impending eclampsia. She was given injection labetalol 20 mg diluted and injection MgSO4 was administered to her 4-gram IV diluted as 20% and 5 gram of 50% MgSO4 in both buttocks. Pritchard regimen was followed. Corticosteroids was administered to the patient. Blood was withdrawn and sent for investigations and cross-matched. Next slide, please. So investigations that we sent on admission showed hemoglobin of 11.8 gram per deciliter. Total leukocyte count was 6,660. Platelets were low, it was 60,000. Liver function test was deranged. Total bilirubin was 2.08. SGOT was 262 and SGPT was 525 international units per liter. They were definitely deranged. Creatinine, although was normal on admission, 0.8. Sodium was 129, potassium was 5.9 milliequivalents per liter, and prothrombin was 35 and INR was 2. Next slide, please. So after blood was arranged for this patient and after consents were taken, patient was taken up for emergency cesarean section in view of fetal distress. Intraoperatively, there was massive blood loss of around 1200 ml. Also, a situs was present. Since there was massive blood loss, multiple hemostatic sutures and delayed compression sutures were taken. We had asked for blood intraoperatively and postoperatively. We transfused her with one packed cell, six fresh frozen plasmas, one single donor plasma, and one random donor plasma. This patient was immediately shifted to ICU post-operatively after her BP continued to remain at 180-110 millimeters of mercury. She was given IV Labet 60 mg post-operatively in the post-op recovery room, but her BP failed to come back to normal. Therefore, she was shifted in the ICU and injection labetalol infusion was started to her. When BP could not be controlled over labetalol infusion, she was shifted to NTG infusion. Next slide, please. On postoperative day 1, though her BP had come back to 160/100, her investigations on the same day showed a hemoglobin of 8.6, total leukocyte count of 7,400, platelets of 28,000, which were in a decreasing trend, total bilirubin of 10.474 milligram per deciliter, AFT of 1,664, ALT of 635 international units, and ALT of 635 international units, creatinine of 3.16, prothrombin time, however, was 15 and INR was 1. Next slide, please. Next slide, please. Patient went into acute renal failure, nephrology opinion was taken, and hemodialysis was done. Patient was also given one packed cells and was given fresh frozen plasma. Post which patient had high grade fever while patient was taken for hemodialysis. As a precautionary measure, COVID RT-PCR was sent after isolating the patient. Patient came out to be positive for the same and was shifted to COVID ICU. Hemodialysis was planned once more after nephrology opinion and one packed cell was transfused. Patient was shifted on to higher antibiotics. Next slide, please. Post which patient was recovering, her investigations were improving, but patient on post-operative day 7 developed wound gape, for which daily wound dressing was done and patient was started on multivitamins and high protein diet. At all this time, the patient was continuously monitored for blood pressure, urine output, and other vital signs. Patient was planned electively for wound resuturing after her quarantine period was over. Tension sutures were taken and patient was discharged after doing check dressing on day 4. Next slide, please. So, discussing this case, we come to HELLP syndrome. HELLP syndrome is a multi-system disease. Results in generalized vasospasm, microthrombi formation, and also coagulation defects. The syndrome seems to be the final manifestation of insult, which leads to microvascular endothelial damage and intravascular platelet aggregation. So 30% of the patients who develop HELLP syndrome will also go into DIC. Unexpectedness, suddenness, and fulminant course of this syndrome are essential. Usual short period of observation after an uncomplicated delivery and uneventful medical history contribute to the risk of missing a life-threatening complication. Next slide, please. The most important symptom of this syndrome is epigastric pain. So this epigastric pain is assumed to be because of the stretching of Glissen's capsule, which is because of sinusoidal obstruction of blood flow. Clinically, DIC as a secondary pathophysiological phenomena to the primary process is seen in 4% to 38%, suggesting an important role of coagulopathy in the etiology of HELLP syndrome. Development of decompensation of coagulation correlates with the appearance of severe maternal complications like renal failure. It is unusual but a life-threatening complication. The HELLP syndrome usually occurs with preeclampsia, like in our patient, which was not regularly controlled. In summary, we present a case of postpartum health syndrome. Our case is successfully managed with timely diagnosis and therapy. Next slide, please. The conclusion is prompt recognition, supportive treatment, and early fetal delivery remains the cornerstone in management. Early diagnosis of women at risk with severe preeclampsia and termination of pregnancy in a tertiary care hospital which is well equipped with blood bank, with ICU and other super specialty facilities also plays a very vital role. Strengthening the healthcare system to detect patients at risk of developing such complications and early referral of such patients is very important. Thank you.
Any questions to Dr. Shruti Shetty? Any questions?
I have a question.
Please
Yes.
ask.
So the question is, we've seen atypical cases of health in which women don't have a proteinuria. Is that
Yes.
also your experience? Women don't have proteinuria.
Yes, there was one case of health syndrome. The patient was an undiagnosed case. The patient had normal blood pressure, no proteinuria, but still developed health syndrome. Usually seen in postpartum women, and they were managed in the ICU well. Their platelet counts had reduced immediately post-operatively.
Because the preeclampsia now, proteinuria is not essential according to the recent
Yes.
guidelines. I'm
Yes.
sure you're aware of that.
Yes.
So probably still we have more diagnosis of HELLP syndrome even in the absence of proteinuria.
Yes.
The other question is, you mentioned giving magnesium sulfate in both buttocks. We usually give it the loading 4 gram IV slowly. So
Yes.
just tell me about your method of giving it IM in both buttocks. What's the reason behind it?
So according to Pritchard regime, the loading dose includes a 4 gram of IV in 100 ml NS diluted
Yes.
as 20%, and 5 gram is given as 50% MgSO4. 5 gram is given as 50% MgSO4 in both the buttocks, 5 gram in each buttock. And then maintenance dose is 5 gram alternatively in each buttock.
So you mean
For
the maintenance?
24 hours, for
the
either
mainten-
24, yes, sir.
The maintenance is IM or IV?
The maintenance is IM. Maintenance dose according to Pritchard regime is IM.
How often?
Sorry?
How
That
often?
is given either till 24 hours from the episode of seizure or from the delivery, from the time of delivery, whatever is later.
All right, that's very interesting because we don't use this regime in the UK like that. We use it IV maintenance.
We usually use this regimen here.
Okay, thank you.
Any questions to Dr. Shruti Shetty? Thank you very much, madam, for participation in this event.
Thank you so much.
We want thank you for insight presentation and looking forward to meet you again in our upcoming events. Thank you. Thank you very much.
Thank you, ma'am.
Now we ask Dr. Radwan Faraj, consultant obstetrician and gynecologist, MRCOG, University of Sheffield, United Kingdom, to join this event and start presentation.
Hello, excuse me. Is it possible to do my presentation in an hour time? I already spoke with the organizing committee. I'm just busy in the clinic now.
Okay, after one talk, is it okay? After one talk.
Yeah, I will try because I already said 12:30 UK time.
Yes, yes.
So
Okay.
I will still be on the line now, but if there is any other presenter will be available, that will be great. Thank you.
Sure, madam. Sure, sir. So, thank you. And now we ask Dr. Haitham Al Sam from Saudi Arabia. Last time some technical problem. He is facing technical problems. So,
Yes, please.
yes, sir. Thank you, sir. Thank you. Just a minute,
Thank
sir.
you
I
very
will
much.
share your PPT.
Can I try to share it here from the phone if it's possible?
Just a minute. Just a minute.
Because this
You
might
can
help
just
me also.
yes. You can try, sir.
If you can give
Yes.
me
Yeah, I have provided co-host.
the permission. Yes. Thank you very much.
Thank you, sir.
So I will proceed. We shall I proceed from the point I stopped at, or
If it's no problem, sir, you can present to start to starting point.
so start over again?
Yes, no problem.
Sure. So the presentation, I'm going to present a case that we had experience with, and then I'm going to touch bases on the management of coronary artery disease during pregnancy. As I mentioned before, that this is a lady, 45-year-old, gravida 7 para 5, at 32 weeks of gestation, when she presented to the emergency room with acute onset of severe central chest pain with radiation to the jaw and back. And her symptoms were associated with shortness of breath, nausea, vomiting, and she had no prior history of angina, was only taking multivitamins pills without any other prescribed medications. She previously delivered via cesarean section due to severe preeclampsia, and her family history is significant for premature coronary artery disease and familial hyperlipidemia. Her father had a previous myocardial infarction, was diagnosed also with diabetes mellitus. Two of her siblings developed coronary artery disease. So she had a significant family history of coronary artery disease. On physical examination, the patient was conscious, alert, and her vital signs, blood pressure was 83/58, and on the right arm, and 102/77 on the left arm. Heart rate was 67 beats per minute. Respiratory rate was 20 per minute. Temperature was 37, and oxygen saturation in room air was 96%. The respiratory system was clear with bilateral equal vesicular breath sounds. Cardiovascular was normal, and her neurological examination was unremarkable. And the ECG showed inferior posterior signs of ST elevation and myocardial infarction. The patient suddenly became hypotensive, and her latest vital signs were like heart rate was 70 beats per minute, blood pressure dropped to 83/58 on the right upper limb. On the left lower limb was 96/63, and of the right lower limb also 102/72. The echocardiography showed a normal left ventricular size with a diastolic dimension of 5.5. Overall, left ventricular function was mildly reduced of 35 to 50%. Her inferior and inferior lateral walls were severely hypokinetic. RV also showed a mild reduction in systolic function, and all valves were normal, both morphologically and functionally. The diagnosis was going with or consistent with acute inferior posterior STEMI and the cardiologist or the interventional cardiologist on call was in favor of proceeding to go for a primary percutaneous coronary intervention. The fetus was assessed at that time. Bedside ultrasound revealed a single viable fetus with appropriate size for its gestational age, measurement equal to 33 to 34 weeks, phallic presentation, and with a normal amniotic fluid index and Doppler. Laboratory was inferior MI, and the patient was counseled fully, and her husband, risk and benefits of the procedure, and was discussed in depth. They agreed to go ahead with emergency life-saving cardiac procedure with clear understanding that it involves risk to the patient and the fetus. The patient also was taken to the cardiac cath and anesthesia, high-risk obstetric and interventional cardiology teams on standby. So it was performed, the cardiac cath, and the finding was ectatic coronaries and plaque disease was observed throughout. She had a drug-eluting stent was placed on the right coronary arteries, and she was planned to go into dual antiplatelet medication. She was discharged on the 5th day of her admission after the staying 24 hours in the ICU, given aspirin and Plavix, metoprolol, and ranitidine. And the challenge was for how long we need to continue. The plan advised by the cardiologist is to go for 12 months antiplatelet therapy. And we planned her delivery at the time around 37 weeks by cesarean section and tubal ligation. When we had multi-sitting of discussion with the cardiologist and the family regarding the Plavix and whether to continue or to stop before the OR, but we choose to do death from thrombosis higher, much higher than the risk of bleeding or death from bleeding. And bleeding we can manage intraoperatively with fluid resuscitation, blood transfusion, and use tonic medication or surgical securing of hemostasis. The surgery went smoothly, and the estimated blood loss was around 400 ml. The patient was extubated in a good general condition and transferred to the ICU. She stayed for another 24 hours there, and she was kept for another 3 days, then discharged in a good condition to discharge home. During her postpartum period, she was seen in the outpatient clinic twice over 1 year, and in cardiology and maternal-fetal medicine for routine follow-up. She was doing fine with no concerns and maintaining her optimum cardiac function. So this is, in brief, the case that we challenged. It was managed well, alhamdulillah, and the outcome was favorable for the fetus and for the mother. In general, the incidence of coronary artery disease in women of childbearing is unclear and varies between countries. Although acute MI or acute coronary syndrome complicating pregnancy is relatively uncommon, like 1.7 to 6.2 in 100,000 deliveries, coronary artery disease accounts for more than 20% of all maternal cardiac deaths. So among cardiac causes of maternal death, it counts more than 20%. Pregnancy is associated with 3 to 4 fold increase in MI risk compared with age-matched non-pregnant women. Risk factors include smoking, maternal age, hypertension, diabetes, obesity, and dyslipidemia. Additional risk factors include preeclampsia, thrombophilia, transfusion, postpartum infection, cocaine use, multiparity, and postpartum hemorrhage. As the birth rate in women more than 40 years increases, then we do expect that acute coronary syndrome complicating pregnancy will become more common. As for every year increase in maternal age, there is like a 20% increase in MI risk. The etiology of coronary artery disease in pregnancy differ from the general population, and the majority of coronary artery disease has non-atherosclerotic mechanism, including pregnancy-related spontaneous coronary artery disease, and dissection, we call it PSCAD, which count for 43%, and geographically normal coronary arteries for 18%, and coronary thrombosis for 17%. Regarding the pregnancy-related spontaneous coronary artery disease, MI occurs most commonly in late pregnancy or early postpartum, and predominantly involves the left-sided coronaries, frequently with multi-vessel involvement. Potential pregnancy-related precipitating factors include fluctuating estrogen-progesterone levels, resulting in structural changes in coronary vasculature, in background of fibromuscular dysplasia or connective tissue disease. Also, the increased coronary share stresses associated with labor. MI with angiographically normal coronary arteries, the mechanism remain unclear and include transient coronary spasm, increased vascular reactivity, and or use of ergot derivatives, rather reflecting the limitations of this diagnostic. Just a second, please. I think I lost my my PowerPoint. I'll bring it back now. I apologize. Yes, I'm sorry again.
Okay, no issues.
So for the coronary thrombosis in the absence of atherosclerosis due to the hypercoagulability of pregnancy and can result from paradoxical embolization. Another thing to stress on is increasing survival in Kawasaki disease. In USA, like an example, it's predicted to be by 2030, by the year 2030, 1 in every 1,600 adults will suffer from Kawasaki disease. And this will present an additional challenge. Relevant Kawasaki disease manifestations include aneurysm, coronary blood flow alterations, coronary stenosis, myocardial ischemia, congestive cardiac failure, and valvular abnormalities. Presentation and diagnosis, usually they present most commonly in the third trimester, okay, or postpartum. Clinical presentation is the same as in non-pregnant population, and the ECG interpretation is also challenging in pregnancy. Serum troponin rise should suggest myocardial ischemia even in preeclampsia. The ECG is non-diagnostic. Echo may be helpful also. The main differential diagnosis, including pulmonary embolism, aortic dissection, and preeclampsia. MI management is in pregnancy is similar to that in the general population, and including revascularization technique. In PSAD or PSCAD, enhanced vascular vulnerability should be considered when applying revascularization strategies. Management should be multidisciplinary, include emergency, include obstetric, anesthesia, cardiovascular team, and it should be undertaken by the most experienced operators due to the attendant risk associated with coronary intervention in this patient population. In case of cardiogenic shock, there should be facilities for emergency mechanical circulatory support. Close monitoring of the mother and the fetus is required with a delivery strategy in place in case there is a sudden maternal or fetal compromise. In case of maternal cardiac arrest, then start delivery should be encountered with all precautions. There's little information regarding the fetal safety of guideline recommended drug therapy in MI. Low dose aspirin appears to be safe. Okay, there's little information regarding other medication. Plavix should be used only when strictly necessary and for the shortest duration as we can. In the absence of data regarding glycoprotein 2B3A inhibitors like divalurode, ticagrelor, yet recommended. Beta blockade may be beneficial in reducing shear stress in such a disease. Recombinant tissue plasminogen activators does not cause the placenta but may induce bleeding complications, especially the subplacental hemorrhage. The benefit of short-term heparinization during PCI probably outweighs the risk of bleeding. And the effect of ionizing radiation should not prevent primary PCI in pregnant patients with standard indications of for the revascularization. Radiation dose must be minimized as much as we can. In a stable low-risk non-STEMI, non-invasive approach should be considered. CT angiography provides an alternative diagnostic method, but it requires radiation, potentially high-dose beta blockade, and may fail to demonstrate limited PSCAD. What about the stent choice and antiplatelet therapy? The majority of reports regarding STEMI in pregnancy relate to bare metal stents. New generation drug-eluting stents are recommended according to the 2017 guideline. Stent choice and antiplatelet therapy, because there is no complication, have been reported in stented pregnant patient treated with Plavix and aspirin, and because pregnancy is high bleeding risk situation, use of a more potent P2Y12 inhibitor should be considered with caution. The duration of dual antiplatelet therapy with a second or third generation dual eluting stent can be shortened, particularly in the absence of great thrombotic burden. Bioabsorbable stent using or usage has been reported in spontaneous coronary artery dissection. However, there is currently no evidence of to recommend them in pregnancy. What about a pre-existing disease? Women with pre-established coronary artery disease are at risk of serious adverse cardiac events during pregnancy, the highest risk of which is seen in atherosclerotic coronary artery disease, with reported maternal mortality reaching 23%. Adverse obstetric outcome occur in equal or less than 16%, with 30% of pregnancy is complicated by adverse fetal neonatal event, most commonly in coronary atherosclerosis by 50%. Pregnancy may be considered in patients with known coronary disease in the absence of residual ischemia and clinical signs of LV dysfunction. There are no high-quality data defining how long pregnancy should be delayed post myocardial infarction, and recommending 12 months seem reasonable in such disease. There is no definitive evidence that a previous PSCAD increases recurrence risk. Avoidance of further pregnancy is advised, and if the patient chooses to proceed, then close monitoring is advised or recommended. What about labor and delivery? The timing of labor must be individualized. Treatment of STEMI should not be delayed for delivery, and delivery should be postponed, if possible, for at least 2 weeks post-MI to facilitate the maternal management. And vaginal delivery still is the preferable mode of delivery. In brief, or in summary, the recommendation in such cases, ECG and measurement of troponin levels are recommended when a pregnant woman present with chest pain. Primary coronary angiography is recommended as the preferred reperfusion therapy for STEMI during pregnancy. An invasive management strategy should be considered for non-STEMI acute coronary syndrome with high-risk criteria. Conservative management should be considered for stable non-STEMI acute coronary syndrome with low-risk criteria. Follow-up should be considered over at least the next 3 months. So follow-up should be considered over at least the next 3 months. Breastfeeding is not recommended in mothers who take antiplatelet agents other than low-dose aspirin due to lack of data and increased risk. Thank you very much. That was my talk, and I really appreciate your patience and listening, and I apologize again for the technical issues happened today. Any questions, please?
Any questions, Dr. Haitham? Any questions? Thank you very much, sir, for participation in this event, and thank you for your patience.
Thank you.
And
Thank you very much.
attention. Yes. On behalf of organizing committee of Gynecology conference, we want thank you for insight presentation, sir, and looking forward to meet you again our upcoming events. Everything goes well, we will meet a physical event.
Inshallah. Thank you very much for inviting me and giving me this chance.
Thank you, sir. Thank you very much.
Thank you.
Now we ask Dr. Devi Novita, Department of Obstetrics and Gynecology, Faculty of Medicine, Asaduddin University, Indonesia, to join this event and start presentation, madam.
Okay, thank you. Am I able to share screen right now?
Just a minute, madam. Yes. Yes, you can start. You can share your PPT.
Okay, thank you. Okay, can I start it right now?
Yes, ma'am. Yes.
Okay, is my poster are seen right now?
Yes.
Okay, thank you. So good afternoon, everyone. Thank you for giving me the opportunity to present.
If you don't mind, enlarge your PPT, madam.
Oh, okay, sorry, thank you.
Screen big or yes, no. Okay. No. Yes. Yes. Okay.
Okay, so good afternoon, everyone. Thank you for giving me the opportunity to presenting my mini research. So first of all, let me introduce myself again. My name is Dewi Novita. I'm a resident of Obstetrics and Gynecology of Hasanuddin University, Indonesia. So today I want to present my mini research about expulsion rate of banded T-shape and plain T-shape intrauterine device after intracesarean insertions. So the aim of this mini research are first to evaluate the general IUD expulsion rate in women who had an intracesarean intrauterine device insertion. So and second, to evaluate the expulsion rate for banded T-shape and plain T-shape intrauterine devices in women who had intracesarean intrauterine devices insertions. So the results are expected to determine the incidence of expulsions of banded T-shape and plain T-shapes intracesarean intersection contraceptives so that it can determine the most effective IUD or intrauterine devices contraceptions. So number of factors known to be responsible for intrauterine devices expulsion. So this include time of insertion, mode of delivery, and the type of IUDs used. So increased puerperal bleeding is thought to cause the high prevalence of intrauterine device expulsion after intracesarean insertions, and it takes around 29.7%. And thus, it is necessary to do an in-depth research regarding multiple factors affecting the incidence of IUD expulsions after intracesarean insertion. So the aim of this study is to describe the rate of expulsion after intracesarean insertion of the banded and plain T-shaped IUDs. So this research is an observational analytic study developed with a cohort research designs, and this research was conducted for 90 days from September 2020 to December 2020 at Wahidin Sudirohusudo Hospital, Hadijah Hospital, Pertiwi Hospital, and Fatima Hospital. And the target population in the study are mothers who will give birth by cesarean section. The affordable population in the study were mothers who will give birth by cesarean section, and the Wahidin Sudirohusudo Hospital operating room, Khadijah Hospital, Pertiwi Hospital, and also Fatima Hospital from September to December 2020. So to determine the distribution of the character of the research subject, the chi-square test was used, and to assess the difference in IUD expulsion rates between the two groups of insertion subject, the independent t-test was used if data were normally distributed, or the Mann-Whitney if the data were not normally distributed. So as we can see in this poster, especially for the first table, we can see. So it is the comparison. So in this table, the first table, it is the incidence of expulsion on day 40. 40 follow-up. So as we can see that at the 40-day follow-up, 31 patients experienced expulsion and the remaining 185 didn't. And expulsion was mostly found on patient age 20 to 35 years old, and it takes around 60.1%, and marriage length of under 5 years, and it takes around 19.8%, and the housewives, it takes around 14.8%, elementary high school graduates, it takes around 15.3%, and is associated with primiparity, it takes around 25.5%, and dysmenorrhea, it takes around 21.4%. So the incidence of expulsion on the day 40 follow-up, as we can see. So this table shows the distribution of the incidence of expulsion based on the characteristic at day 40 by age. Patient who experienced expulsion had the highest proportion in the range of 20 to 35 years age group. It takes around 79.6%, and the lowest proportion in the under 20 years age group. And from the statistical test result obtained p-value around 0.279, which means there is no difference in the proportion of the incidence of expulsion based on the age category. And then based on the length of a marriage, patient who experienced expulsion had the highest proportion in the less than 5 years group, and it takes around 90.8%, and the lowest proportion in the more than 10% group, it takes around 3%. And from the statistical test result, it obtained p-value more than 0.05, which means that there is no difference in the proportion of expulsion in the category of line of marriage. And then by occupation, patient who had expulsion had the highest proportion on housewife. From the statistical test result, obtained p-value more than 0.05, which means there is no differences in the proportion of expulsion events in the type of work. And based on the education, patient who experienced expulsion from primary to high school were 15.3%, and that is going to university college at around 5%. From the statistical test result, obtained p-value more than 0.05, which means there is no difference in the proportion of the incidence of expulsion at the educational levels. And based on parity, patient who experienced expulsion had the highest proportion in the primiparous category. It takes around 25.5%, and the lowest proportion in the grande category. It takes around 10.5%. From the statistical test, thus, it obtained p-value around less than 0.05, which means there is differences in the proportion of expulsion events in the parity category. And based on the type of menstrual disorder, patient who experienced expulsion had the highest proportion of this menorrhea. It takes around 37.1%. So at the next table, as we can see, that is a comparison of the proportion who experience expulsion between 40 days follow-up and 90 days follow-up. So as we can see in this table, upon 40-day follow-up, 14.4% of patients experienced expulsion. Expulsion was significantly higher on the banded T-shape compared to the plain T-shape IUDs, and it takes around 24.4% versus 8.3%. And it obtained p-value less than 0.05, whereas there was a marked decrease of incidence. It takes around 4.9% with no significant difference of expulsion rate, and between both groups on 90 days follow-up. So as we can see that in this table, that from the research, it was found that on the day 40, the expulsion on the plain T-shape IUD was 8.3%, while the banded T-shape was 24.4%. And from the result of statistical test, there was a difference in the proportion of expulsion even between plain T-shape and the banded T-shape, where the incidence rates was expulsion of banded T-shape of IUD was higher on day 40. Meanwhile, at 90 days, those who experienced expulsion on plain T-shape IUDs were 5.1%, and banded T-shape IUDs were 4.7%, and plain T-shape with banded T-shape. And then IUD expulsion is, as we know, that is a release of IUD from the uterus, and most commonly occurring happen to 30 to 90 days after insertion. And expulsion occurs more frequently in the first 3 months of the insertion, after which the incidence rates drop sharply, and this is due to anatomical and physiological changes during the puerperium that can increase the risk of expulsion. And for the discussion, as we know that expulsion is more common in the first 3 months after insertion, as what I explained before, that is because due to the anatomical and physiological changes during the puerperium, such as uterine subinvolution, excessive contraction, and persistent dilatation of the cervix as a result of excessive lochia pass. And then lower rate of expulsion on the plain T-shape IUD is associated with its flexible horizontal arms, which that allows for adjustment into the uterus, as well as a unique insertion technique that require less cervical width and less bleeding. And in a study conducted by Sivin, it was found that the high incidence of bleeding in banded T-shape IUD recipients was the main reason for the high rate expulsion. So as my conclusion in this mini research is expulsion is most common after 40 days and decreases after 90 days. And the plain T-shape has less incidence of expulsion compared to banded T-shape IUDs. Thank you very much. Maybe that's all that I can explain.
Thank you, madam. Any questions to Dr. Devi Novita? Any questions? Thank you very much, madam, for participation in this event.
Yes, thank you. Thank you very much for this opportunity.
And on behalf of our organizing committee of Gynecology Conference, we want to thank you for insight presentation, and looking forward to meet you again in our company with upcoming events. Everything goes well, we will meet you physical event, live events, physical events in future. Thank you very much, madam. Now we ask Dr. Bhagyasri, Katihar Medical College, India, for poster presentation.
Thank you. My poster visible to you?
Yes, but enlarge your PPT, madam. Your poster, please enlarge. Visible but too small. Yeah. Yes, click the from beginning.
Second, actually, it's not visible on my screen, so I'm just waiting for this to come.
No worry, madam. We have a lot of time. No problem. Please check it. Madam, if you have no problem, I will pay. No. If you have facing any issues, please share your PPT, madam. Hello.
I'm telling that I'm not able to share it. Can you do it for me, my poster?
Yeah, please share. Please send me, madam, through WhatsApp. We will play behalf of you.
I have made a PPT also of this poster. Should I play that PPT rather than displaying the poster?
1 second. Poster, yes, we got it. Just a minute, madam. Stay on the line. Okay.
Yes.
Yes.
Thank you. I'm just able to see the half of it. How will I be
Yes.
seeing the?
That is a.
You'll be down, scrolling
Yeah.
down, huh?
Yes, yes, ma'am. Just tell me. Next, I will move to down.
Very good evening to everyone. I'm privileged to be a part of this conference, and I'm overwhelmed. I'm Dr. Bhagyashree, the final year PG student from Department of Obstetrics and Gynecology, Katihar Medical College, India. And I am presenting my poster on the topic, a rare case study of ovarian torsion in a 6-year-old girl. So we had come with a case of ovarian torsion in a 6-year-old girl, and that is not a very common picture to show. So this was a case done in my college only, Department of Obstetrics and Gynecology, Katihar Medical College, which I have here. So the basic introductions regarding that. Ovarian tumor in childhood encompass a variety of benign and malignant tumors. As we know that overall the maximum percentage of ovarian tumors are that from the epithelial origin, but in the childhood, the most common tumors are germ cell tumors, and so there are different kind of tumors that could be encountered, whether it be benign or malignant, and that includes germ cell tumor. There could be surface epithelial stromal tumors. There could be sex cord stromal tumors, or there could be the mixture of them, like a combination of germ cell and sex cord stromal tumors. So there are different kind of these tumors in as we have come to know, and there are different kind of complications also, but in childhood it could be complicated by a torsion or a rupture. So there are certain tumors who undergo torsion more, and there are certain tumors who have undergone rupture more. So there are different kind of complications that can occur depending on what kind of ovarian tumor it is and what age it manifests to, what type of histological tissue it originates from, how big is the tumor, what was the precipitating cause that could lead to the torsion or the inciting factor for the torsion, and there are certain manifestations for the rupture as well. There are other complications also, like infection could happen, or there could be malignant change in a tumor. So few benign tumors could convert itself into the malignant tumor, and then we find certain changes and certain manifestations that could alert us regarding that. So this is the basic introduction. Although ovarian neoplasm in childhood are rare, the diagnosis should be considered in young girls with abdominal pain and palpable mass. So although ovarian neoplasms are rare in childhood, but since we know that the most common tumors that occurs in childhood are germ cell tumors, so if a girl comes to us like for abdominal pain and intense acute abdominal pain, and you find a palpable mass in the pelvis, so you should always have a diagnosis of ovarian tumors in mind. There could be other complications or other diagnoses as well, but we should definitely have in our mind that okay, this could be a kind of appendicular mass, this could be ectopic kidney, this could be have that thing in our mind that okay, the ovarian tumors. So this was basically there. So the aim and objective, the aim was to present a case of ovarian cyst which was complicated with torsion in a 6-year-old girl who has come to our college, and so I'm presenting regarding that. So the material and methods. This study was a hospital-based case study. So the place was in Department of Obstetrics and Gynecology, Katihar Medical College, Katihar, India, and the time period was the patient have been following the patient the time of discharge also, and later also follow-up were also there. So till 29th of December 2019. Could you scroll it down, please? I can do it. Thank you. So the case summary was a 6-year-old girl presented in the emergency department with complaint of pain abdomen since 10 days. So she had come with pain abdomen and she was telling that the pain was, first it was very insidious and dull aching pain, but what made her come into the emergency department was she was having a sudden acute onset of pain. So she was having acute pain in nature, and it was non-radiating in nature, and it was found in the lower abdomen. And when I asked her, she told that this pain, I had her guardian were telling that she was having little aching pain, a very dull kind of pain in the lower abdomen before, but so that subsided, and she was taking, she's playing games. So that time she was having aggravation of pain, for which she favored to take rest alone. So a history of nausea and vomiting was also there, and that nausea, she was when there was pain, sometimes there was nausea and vomiting, and that was not a projectile vomiting, that was a non-projectile vomiting, and the nausea and vomiting was associated with increase in the pain. So when there was a increase in pain, then only the nausea and vomiting was associated with it, not like otherwise. No significant past medical or surgical history. So that kind of history in her life was in the past, or she was not having any medical history as such. So like she was not having any history of juvenile diabetes, or she was not having any history of jaundice, she was not having any history of breathlessness, she was not having any history of hypertension, she was not having any history in her family as such. So I also encountered about the same kind of history, that okay, any kind of lump abdomen or any kind of tumor, or was any associated history or disease in her family, like in her mother, or like in her father, or first degree relatives, or second degree relatives, but I did not find any kind of such relevant history in her as well as in her family. So clinical examination was, when she came, she was alert, she was conscious, and she was well oriented. She was answering all the questions I was asking. So she was well oriented and she was conscious, and she was agonized with the pain that time. And the build was averagely built. So her build was average. And okay, thank you. Yes, and secondary sexual characters were absent, because I wanted to differentiate whether this kind of a hormone-producing tumor or something like associated with it. So I had also seen different kind of sexual characters who develop precautiously, but her, and her blood pressure was 90 by 60 mm of Hg, and I took this blood pressure at 2 intervals at 4 hours apart. And but initially when also she came, I noticed her blood pressure, and after when she was stabilized a little bit, then also the blood pressure was 90 by 60 mm of Hg. Her pulse rate was 76 beats per minute, and the pulse was regular in rhythm. It was fair in volume, and I also palpated all the peripheral pulses. So all the peripheral pulses were palpable. So there was also no radial or radiofemoral delay as I saw, and the volume and the character was also okay. And the temperature was 98.2 degree Fahrenheit. She was basically afebrile. She was not having any fever as such. And I counted the respiratory rate. So respiratory rate was 16 breaths per minute. I noted the respiratory rate. The saturation was 98%. So all these parameters I took into account. Now I saw for the general examination, and since the patient was agonizing in pain, she preferred to lie down only, tossing in the bed. And the pallor was, mild pallor was there. There was not a severe pallor, and icterus was not there, cyanosis were not there, clubbing was not there, lymphadenopathy was not there, and even edema was not there. there. Then I palpated for the respiratory systems also for any significant finding as such. So first I also asked about any kind of breathlessness or any kind of tuberculosis history in her family that could that is common in the tropical countries, but it was not there. The chest was bilateral clear, and I could hear the bilateral vesicular sounds on the both sides, and I could not find any other added sounds in her chest when I ausculted the entire areas as such. Now I also looked upon the cardiovascular system, and I did not find any gross or any abnormality in her, and the bilateral S1 S2 were heard, and no other added sounds or murmur or any kind of other added sounds were heard also. Then I came for the per abdominal examination in her. So while I saw the abdomen, the per abdomen, I saw that there was no sign of inflammation. There was no redness, there was no edema, there was no hyperperistalsis as such. But even on looking on inspection, I could not find a lump. I could not see a lump or a gross swelling in her abdomen, and the umbilicus was central in position, and it was everted, and there was no any fistula present, there was no any sinus present, there were no any surgical scars present. So all these things were normal on inspection. Then on percussion, I palpated her abdomen. On palpation, I found tenderness and tenderness highest in lower pelvic area, more in the right, more and tender was almost 5 centimeters. Lump was smooth surface, and the lump margins. The lump was not a multi-node lump, was restricted. So the lump, and I the lump, the on the there also, and I'm not on that. So it okay, this of origin. After that, doing percussion, that provided that, and then I treated for all sounds were immediate that some parameters like hemoglobin 11.4 million and ABURS all the viral markers were detected. AG was non-reactive and total leukocytes in this patient was 1800 milliliter. Her electrolyte was so it was 100. Her was gram per day. That was 0.7 per.
Hello. Hello, Dr. Pagisri. Are you there? Thank you. Thank you very much, madam. It was nice presentation.
Hello?
Yes, hello.
Yes, am I audible?
Yeah, yes, madam.
Yeah, a little bit is spared. A little part is spared right now. I have not
Okay, okay.
completed.
Yes, okay, no problem, no problem.
Can you see the poster?
Yes, yes. Is it here? Okay.
Hello.
Yeah,
Yes.
yes, madam. Yes.
You can see my poster, right?
Yes, madam. Please go ahead.
I'm trying to complete it fast. Yes. So then investigations were done. She was also having an ultrasonography with that. A large heterogeneous mass, 4.8 into 3.6 centimeter, was there in the right lower quadrant, and contrast enhanced CT revealed in large right ovary with infarction necrosis that was sequelae of ovarian torsion in that patient. So pre-operative preparations were done, injectable antibiotics were done, and as that was an emergency situation, hello?
Yes, madam, yes. Please check your audio settings.
Can you hear me?
Yes, madam, yes. Proceed, proceed. Yes, madam, proceed, proceed. You can start your presentation. Yes, yes, you can do it.
I think network weak
Yes,
here.
maybe technical issue or something. Okay, no problem. You can do it. Hello. Hello, madam.
Yes. Antibiotics and emergency is the procedure. Scientific precautions, emergency laparotomy is done, and
I think Dr. Bhagisri is facing technical issues. She will be joined within 1 or 2 minutes. Some internet connection problem.
Hello. Can
Hello.
you listen to me?
Yes, yes, madam. Proceed.
Okay. So we found that under aseptic precautions, emergency laparotomy was done. Right ovary was enlarged approximately 5 into 5 centimeter, was brownish in color and contained hemorrhagic fluid inside. Right ovary had 3 turns of torsion around the ovarian pedicle with compromised vascular supply of nearby tissues. Right fallopian tube was twisted at corner and stretched over the mass.
Again, disconnection.
Adhesions were removed and detorsion was done. Right salpingo-oophorectomy was done. Contralateral ovary and fallopian tube were normal. Hemostasis secured. Abdomen was closed in layers. Specimen sent for histopathological examination. So post-operative antibiotic coverage was given. Intraoperative post-operative period were uneventful, and patient was discharged on the 9th post-operative day and followed on OPD basis. So result was histopathological examination showed revealed
Hello, madam. Is not your voice is no voice is coming, madam.
I don't know, the network is too weak to say that.
Okay. Understand.
Yes, 2 lines are there. Patient was discharged on 9th post-op day and followed on OPD basis. Histopathological examination revealed hemorrhagic ovarian cyst and negative for malignant cells. So conclusion was prompt diagnosis and emergent surgical intervention was key to the salvage. Ovarian salvage, especially considering the sensitive nature of ovarian loss in prepubescent period. Our patient was unable to undergo ovarian salvage of the right side as vascular and differential diagnosis was appendicitis, diverticulitis, ruptured ovarian cyst, ovarian mass. Thank you so much.
Thank you, madam. Thank you, doctor. Thank you very much for participation in this event. We want thank you for insight presentation and looking forward to meet you again next time.
Thank you.
Thank you very much. And now we have just 10 minutes. We have 10 minutes break and join the event sharp 5:10 exact 5:10 p.m. as per Indian EST timings. Just 10 minutes break. Attention to all. Shall we start? Now we ask Dr. Weilingham, Medical Acupuncture and Pain Management Clinic, Brazil, to join this event and start keynote presentation.
Can you hear me?
Yes, madam. Yes. Please share your PPT.
You need to enable me to share the screen.
Able to. 1 second. We have already.
I am using the computer and my iPhone. You need to allow the computer.
Yes. Just you can try once again.
Try again?
Yes,
okay.
Yes. Yes.
Can you see? No?
Yes.
Can
please,
you see the Natasha?
Yeah, please enlarge your PPT, madam.
What?
Enlarge your PPT.
Enlarge, okay. Oh. I don't know how to do. Let me see.
This is the last one. Okay, no problem. Click slideshow. Click the slideshow button. Slides.
I don't know how to do.
Okay, no problem, madam. It's visible.
Can you see?
Yes, madam. Yes, you can start your.
Okay. Good morning, good afternoon, good evening to everyone. My name is Wang Weiling. I'm a medical doctor from Brazil. I'm very happy to be here today to share this study entitled Chakras Energy Deficiencies as the main cause of infertility in women. I would like to thank the organizing committee to inviting me to this conference. I would like to say that I'm not a gynecologist, I'm infectious disease, but for the last 25 years, I've been working with traditional Chinese medicine in my own clinic in Brazil. So this presentation today will follow in Hippocrates' code that said it's important to consider other ancient medical traditions prior to the knowledge we have nowadays. So today, I will give you a presentation about some traditional Chinese medicine and Ayurvedic medicine point of view. Over 100 million heterosexual couples worldwide are physically unable to have children, and infertility affects both women and men. And according to Western medicine, genetic disorders, infectious and non-infectious disease, and exposure to certain chemicals are among the causes. In low and middle income countries, infertility treatment is often unavailable for most people. 2010 study in Brazil found that 3/4 of its states do not offer infertility services at government health clinics. In China, infertility affects many couples, and for most, the treatment are too expensive, not easily accessible. In India, couples who are unable to conceive face an uphill battle in their attempts to have a family. The country can offer the most advanced reproductive techniques to circumvent infertility problems, but for most couples, the treatment are too expensive. And culturally, the pressure for Indian women to Indian propagate the family name is also a factor. The prevalence of infertility in Africa is among the highest internationally. A band of countries across Central Africa has been termed Africa's infertility belt. Studies suggest that fertility problems that often stem from infections that have gone untreated, including a history of female circumcision, sexually transmitted diseases, pregnancy complications, and genital infection. It's estimated that infertility is responsible for 45 to 65% of gynecological consultations. In this slide, it can be seen the map of infertility throughout the continent. And normal fertility in Western medicine has been defined as achieving a pregnancy within 2 years by regular and protected sexual intercourse. However, many define infertility as the failure to conceive after 1 year of unprotected intercourse. And infertility can be primary in women who have never conceived or secondary in women who have previously conceived. In Western medicine, the causes of infertility in women can range from ovulation issues, old age, endometriosis, unhealthy body weight, and abnormal cervical mucus. And ovulation issues may be caused by polycystic ovary syndrome, which is a hormonal imbalance that can interfere with normal ovulation. And primary ovarian insufficiency, also known as premature ovarian failure, is when your ovaries stop working properly before age 40 and affect your release of eggs and chances of pregnancy. And hyperprolactinemia is where you have too much prolactin, the hormone that stimulates breast milk, and that may also interfere with ovulation. And thyroid issues will also affect a woman's ovulation cycle. With endometriosis, the tissue lining the uterus starts to grow in other places, like behind the uterus, in the fallopian tubes, in the abdomen, in pelvis, or the ovaries. That causes irritation and scar tissue development. In most cases, endometriosis makes pregnancy difficult, not impossible. In the worst cases, the condition can cause blocked fallopian tubes, disrupt implantation, and cause inflammation in the pelvis and impact egg quality. The tests done in men to analyze infertility may be semen analysis, hormone tests, genetic tests, testicular biopsy, imaging, and rare cases, other tests to stimulate a semen specimen for DNA abnormalities. In women, the tests may be ovulation testing, hysterosalpingography, and ovarian reserve testing. In Western medicine, the treatment for men's infertility may include intake of medication to increase the sperm count, as well as surgery for certain conditions. And for women, the treatment may include medications to stimulate ovulation, intrauterine insemination, or even surgery in some specific cases. Now I'll begin to illustrate this presentation. I will show you I think 2 or 3 case reports that I treated myself using Western and traditional Chinese medicine tools. This first patient is the 35-year-old woman who searched my clinic when trying to get pregnant for her second child. In her first pregnancy, she received treatment also with TCM tools using auricular acupuncture, systemic acupuncture, Chinese dietary counseling, and moxibustion sections together with the IV fertilization treatment, and was able to give a pregnancy successfully in 2014. And this was her treatment, the moxibustion, to give her energy, because her diagnosis in TCM was kidney iron deficiency, a deficiency in the kidney energy that is responsible for the reproduction and sexuality, and also Chinese dietary counseling and acupuncture. And I did in this second pregnancy, trying to have pregnancy, I did the chakras energy measurement, and what I found that, sorry, all her chakra were in the lowest level of energy. Chakra means energy centers that controls the body functions and are invisible by the naked eye because it's formed by energy, but they command the functioning of all organs and systems inside the body. In the case of reproduction system, the chakra that is responsible is the second chakra, governed by the kidney energy in TCM. And as you see, the kidney was in the lowest level of energy. But to treat the kidney, I needed to treat all the internal organs together, because according to TCM, all the internal organs are interconnected by the energy flow. And it's not possible only to treat the kidney, because kidney receives energy from the lung, and lung, as you can see, do not have energy. It's like a battery, do not have battery to maintain the reproduction system, and all the organs and tissues were not working properly. And in her case, her exams, laboratory exams, are very normal. She didn't have any alteration in the laboratory exams. But in the energy point of view, she has this lack of energy. And this is very important to you to understand that when the woman has a difficulty in getting pregnancy, even if she have normal laboratory exams, she could have these energy deficiencies, and that's why you need to treat this deficiency, because it gets more than 5 or 10 years of energy deficiencies to lead to alterations in the laboratory exams. And that's why in her case, I give her highly diluted medication such as homeopathy, but it's not in globules such as in this figure. It's a single doses of one homeopathy for each chakra that I will show you. And after this treatment, she could have a baby. The second baby was a girl, and in this case, a specific case, she needed to do the IVF to get pregnant, because her husband didn't go to do the same treatment of these chakras energy deficiencies, because I know that he could have deficiencies in energy, because in a research that I did in my clinic from 2015 to 2020, I found that the majority of my patients do not have any energy inside the chakras, independent on the diagnosis. And that is why when the woman has infertility, the man needs to do the treatment of the energy, even if the laboratory exams of the man are still normal. In the case reported 2 is a couple that PNR, they were 31 to 32 years old, respectively, were together for 5 years when they first started trying to get pregnant without success. They were trying for 5 years using Western medicine treatment without getting pregnant. At first, no issue was diagnosed. The laboratory exams are normal, but the men had low sperm count, and they found that low vitamin D. The second battery of exams, a urological exam, identify lack of spermatozoids. Where there was supposed to be 20 million, there were 12 million spermatozoids. And the husband started to use Indux, the clomiphene, during 3 months, but the spermatozoids dropped even more, from 12 to 11 million. And the doctor had diagnosed varicocele and oriented the husband for surgery. But I will show you why using this medication, the spermatozoids reduce and not increase. And here is to show you that they were taking this medication to prepare to do this induction. And the couple searched for an assistant reproduction clinic in April 2018, and they decided to realize the treatment very expensive and trying according to the patients. As the issue of the couple was the spermatozoids and in vitro fertilization appeared to be a good option, both patients used clomiphene medications again. And they collected the eggs and waited for the transfer day. 10 eggs were taken, 4 of them were mature, and 7.2 million of progressive spermatozoids. And the 4 were fertilized and 2 were transferred. And the other 2 were left to be frozen, and 2 of them stopped developing. And she did not get pregnant with this treatment. A few months later, the husband performed surgery for varicocele, and even with new attempts after, the treatment was still not successful. And after all the failed attempts, the couple started treatment with me using traditional Chinese medicine tools. And after measuring the patient, both patient chakras, they were both in the lowest level of energy, mainly the kidney that's responsible for the sexual function and the reproduction were in the lowest level. And when the kidney energy is in this kind of don't have energy, they will not send energy to the organs, to the ovary, and to produce the sperm. And then after we do this treatment, replenish these organs, and doing the Chinese dietary counseling, avoiding the ingestion of dairy products, coffee, soda, matiti, cold water, and all the foods that could induce the kidney, reduce the kidney energy or reduce the spleen energy that is responsible for the absorption of nutrients. All patients receive this dietary counseling. And on April 13, 2019, the couple they decided to do an adoption. And 1 month later, they find out that she was pregnant. After the exam, she confirmed that the baby would born in January last year. And they did this. After 5 years of treatment with Western medicine tools, they only wait for 1 month of treatment using replenishing of the chakras energy, and it was able to get pregnant using this kind of treatment. After both case reports, now I'd like to discuss the treatment offered to both these couples. and why they were effective according to traditional Chinese medicine. To comprehend why the treatment was effective, we need to focus on energy concepts. Everything in the world is formed by energy, and matter from which everything in the universe is made of is formed of energy in an infinite arrangement of atoms made up of particles that are in constant state of circular motion. Matter is what can be seen by the naked eye. What is invisible is energy. And everything that exists in our universe is formed by energy, including the human body. To better understand why the treatment was effective, it is important to understand the main principles of traditional Chinese medicine. Health is related to these dynamic forces between these four energies, yin, yang, qi, and blood. And all the treatment aims to rebalance these four energies. In all treatment that I usually do in my daily practice, in all kinds of diagnoses, in this case, to treatment, the treatment of infertility in women and in men too. And this is a symbol of yin and yang, that are two opposite forces present in everything in the universe and inside the body, and their balance is of major importance for the body's health. If there are imbalance between these two energies, the appearance of symptoms occur, and if not properly treated, consolidate as a disease in the future. And this diagram shows yin and yang, and the symbols demonstrate the arrangement of dark yin and the light yang. And this symmetry, however, is not static, is a rotational symmetry that eloquently suggests a continual cyclical movement. This chart represents the various combination of yin yang, qi, and blood, present on a sample of 100 patients in my clinic. And each combination can generate several different physical and emotional symptoms of our disease. And when the patient has these energy deficiencies combination, the treatment aim to rebalance these deficiencies, leading to these normal flowing state between these organs and these energies, leading to a healthy state of the patients. Here's to show you the 5 elements theory, is another theory in TCM, that all internal organs are interconnected, different from the Western perspective, where each organ are working independently and not depend on the other. In this chart, you can see that there are 5 elements: wood, fire, earth, metal, and water, and each element represents one massive organs inside the body. Wood represents liver, fire, heart, spleen, earth is spleen, metal is lung, and water is kidney. In this case, kidney is our main organ, responsible for the reproduction and sexuality. And as I show you, all these internal organs were in the lowest level of energy. And these I found using the radiesthesia procedure. This is not a very common use in China, because they usually use to see the pulse of the patient, measuring by the wrists, using the fingers to see the amplitude of the pulse in the wrists. But in my daily practice, I saw that the radiesthesia is easily for the patient to see their energy state. And using measuring this radiesthesia, I can know how is the energy of the internal organs, that because each internal organ is responsible for the formation of yin yang, qi, and blood. For example, the water element or kidney is responsible for the production of yin and yang, And the earth element is responsible for the absorption of nutrients and production of blood. And the wood and leaf lung is responsible for the distribution of this energy to the entire body. And the heart is responsible for the normal flowing state of the blood inside the vessel. In this chart, you can see that each element in the 5-element theory is responsible for one external sensorial organ, and they have color, taste, climate. Each element has their characteristics. But what I want to show you here is the water element is represented by the kidney, is responsible for the hearing process, but is also responsible for the reproduction, sexual function, bones, teeth, and the memory and concentration, and the youth. And here's to show you the importance of treating this kidney, because if you measure the energy of these patients that have infertility, you can see that all of them do not have energy inside the organs. And that's why it's very important to treat these energy deficiencies, even if the laboratory exams are normal. Here's to show you one publication showing the correspondence between the 5 elements and the chakras energy centers in Ayurvedic medicine. And here's to show you the author described the pineal gland as a link between our external environment and the network of the body system, comprehending the chakra system and the extension of the body's working system. The kidney essence is necessary to provide adequate nourishment of the uterus and creates an appropriate environment for the implantation. And when the kidney energy is deficient, may lead to malnutrition in the fetus and incapable for supporting the implantation. Here's another article saying that the use of Chinese herbs to tone the kidney to fortify the endometrium in infertile women. And the treatment of these patients with infertility needs to be a holistic approach, needing to not only studying the ovary or the sperm, but this depends on the other organ, and including the mind, the spiritual part, and all the organ and system need to be in harmony to achieve this result of a good to have a baby. Here's the Chinese dietary counseling, avoiding in all cases dairy products. Dairy products can reduce the absorption of nutrients, leading to less formation of energy, and also cold drinks, especially water, raw foods, and sweets can also imbalance and reduce the absorption of nutrients, leading to a weakness state of the patients, and also to avoid the coffee, soda, matcha tea, because all these drinks could induce the kidney energy, leading to more deficiency, leading to difficulty in getting pregnancy. His is a Hippocrates book written by Elizabeth Craig that according to Hippocrates, made your food your medicine, your medicine your food. And the first step in all treatment is to change the dietary aspect to maintain the balanced energy state. Here's to show you one publication about the importance of food in Chinese to balance the yin-yang energies inside the body. According to Hippocrates, let your food your medicine, your medicine your food. And also I did acupuncture to rebalance and to produce the yin and qi and blood energies inside the patient's body. And as I show you, the blood is very important. We treat the blood quantity of the patient, even if the patient have normal blood count in the laboratory exams, she could have blood deficiency in the energy point of view. And one of the questions that you need to ask the patient to see if she had normal energy of blood is to ask her if she had daily bowel movement. But if she said, oh, I don't have daily bowel move, I only have once a week or one every 2 days, this could mean blood deficiency, and you need to treat this deficiency to have an adequate blood to get pregnancy and to nourish the baby inside the uterus. Here's another study that I presented in this acupuncture congress in 2009 in Greece, where I show you that acupuncture is very important in the treatment of azoospermia. This was a patient that do not have sperm in his laboratory exams, but after 3 acupuncture sections, his sperm count went to 200 million sperms, and he was able to have a baby girl. And also some publications regarding acupuncture as a treatment for infertility for both men and women. It's very when the patient associate TCM tools in the treatment, the results of improvement of their result in achieving to have a baby is very more positive. This is to show you that chakras energy you cannot see by the naked eye. If you want to have a good result, it's very important to treat this deficiency in all patients that have difficulty in get pregnancy. Here's to show you a chart that to show you the progression from health to disease is divided in 5 phases. The first 3 phases are in the energy point of view, where the laboratory exams are normal. And when the patient is complaining that they have difficulty in getting pregnancy, but the laboratory exams are normal, this does not mean that the patient do not have anything. They have energy deficiencies, and you need to treat these patients. Even the laboratory exams are normal, and the treatment should not be used by using high concentrated medication, because these medications can induce reduction in the vital energy even more, and that is why I'm using highly diluted medication. In this case, I'm using homeopathic medications. Here's another theory that I created in 2000. I began to write in 2015 when I began to study homeopathy in Brazil. And during this course, I began to write this new theory to treat the chakras energy deficiencies using homeopathy. This is different from Chinese perspective, because in China, they usually use Chinese herbs, but in Brazil, it's more difficult to have these herbs, and that's why nowadays I can treat the patient using traditional Chinese medicine reasoning, but using highly diluted medication. That's very important to increase even more the vital energy of my patients. And as I show you in my research, in my clinic, more than 90% of the patients do not have energy, and that is why nowadays I only using homeopathy to treat all kinds of the disease, infectious or non-infectious disease, because this kind of medication can increase the vital energy, different from the use of high highly concentrated medication that could worse. And that's why the patient in the case report 2, her husband were using Index to increase the sperm, and the result was that his sperm count went down more because this kind of medication reduce the energy and reducing the result. And that's why it's very important to increase the level of energy of our patients. And here's the result that I show you from 2015 to 2020, from a child and to older patients. All of them don't have energy in the chakras energy centers. I believe that this result could be from the influence of the electromagnetic waves in our lives, harming the vital energy. And that's why we are in this situation about the increasing disease among very young people, such as the increase of diabetes, myocardial infarction, cancer among our patients, because energy means immune system. And when the immune system is very weak, we have propensity to have any kinds of disease, or in COVID-19 infection also. We are seeing that also children and young adults, and not only older patients, are getting sick or are dying from this disease, probably because of this lack of energy. And the conclusion of this study is that the normal exams in a couple in infertility treatment does not mean they are healthy. The case have to be analyzed in the energy level. And one way of analyzing it is through the chakras energy measurement. And the treatment should be using highly diluted medication and not high concentrated medication. And in this study, I show that in this case of infertility, it's very common to treat only the woman and not the man, but both men and women needs to treat the energy deficiencies to achieve the pregnancy, because as I show you in this research I did in my clinic, all the patients, including men, women, and children, were in the lowest level of energy. And as said by Hippocrates, natural forces within us are the true healers of the disease. Here's the publication of this presentation. You can find at the internet. Thank you for your attention. If you have any question, I would be very happy to answer it. Thank you.
Thank you, madam. Any questions to Dr. Wailing? Any questions? Okay, thank you very much. Thank you very much, madam, for presentation in this event. On behalf of organizing committee members, committee of Gynecology conference, we want to thank you for insight presentation. And this is the second time you are attending our conferences. And thank you for your support and help.
You're welcome.
Thank you. We'll look forward to meet you again next upcoming conferences. Now we ask Dr. Radwan Faraz, consultant obstetrician and gynecologist, MRCOG, University of Sheffield, United Kingdom, to join this event and start presentation.
Hi, thank you very much for allowing me to present this presentation. Can you see my screen, guys?
Yes, sir. Please share your screen, PPT.
You can see it, yeah?
No. Please share your PPT.
Okay, share screen. How about now?
Yes.
You see it now, yeah?
Yeah.
Okay, so my topic today is when not to operate on adolescent girls. As probably you're aware, I will try to cover this topic because very important topic for adolescent girls. We try to operate only when it is required, and I'd like to make this presentation opposite to what everybody thinks. When to operate, I decided when not to operate. So we will try to reduce the unnecessary intervention for these young girls. So I am Radwan Faraj, consultant obstetrician gynecologist in United Kingdom. I work in Rotherham Hospital, and my interest is benign gynecology and adolescent gynecology and infertility. This is where I work in South Yorkshire, a beautiful part of the country. The outline of the talk will be field of adolescent gynecology, a little bit on ovarian cyst, pelvic pain. I will cover on menorrhagia and genital tract injuries, and then we'll end with a summary. None of us would like to see young girls hospitalized for a long time, paying the price of unnecessary interventions. So what is adolescence? Adolescence is a transitional phase of growth and development between childhood and adulthood. So the age, as per WHO, is between 10 and 19. It's divided into early, middle, and late. Early is 11 to 14, middle 15 to 17, and late adolescence is 18 to 19. So it's actually the whole science or the whole branch of reproductive gynecology and adolescent gynecology. To provide a comprehensive patient care focused on the diagnosis, medical and surgical management of these growing girls. So the additional or particular attention to the problem is really important because it's complex medical and psychological area that need highly skilled approach. The medical attitude on the problem will have two extremes. Either people will be indifferent. Do we need to intervene? This could be indifference or ignorance, or it could be the opposite extreme, which is overzealous interventionism. And obviously, moderation is required. In your consultation, you need to focus on the interview with this adolescent girl. And this is very important part really of the management really. You have to be sensitive, make your client comfortable as possible, and upfront to describe the role of confidentiality. Adolescents need to have the utmost confidentiality and reassure her, including the parents in that. And good communication between the daughter and her parent is encouraged. We should be available with your local regulations in your local area and your regulatory body really in that. There is an mnemonics HEDIS interview offer a systematic approach to obtain a psychosocial history, which is important to be sensitive. So HEDIS stands for H for home, E for education and employment, E for eating, A for activities the young girl is doing, drugs, you know the importance of drugs in similar situations, sexuality, whether he is sexually active or not, suicide and depression, and then safety and spirituality. I thought this is an important mnemonics that we can follow. So the adolescent girl, the encounter, the problem that we see is delayed puberty, menstrual irregularities. Some girls come with heavy periods, adolescent dysmenorrhea, very common, painful periods, hyperandrogenism. Girls come with facial hair hirsutism, ovarian masses, trauma and sexual abuse, and vulvovaginal disorders. Again, approach is effective counseling, preventative measures better than treatment, and always try to encourage conservative approach. So we're going to start with ovarian cyst. There is a British Society for Pediatrics and Adolescent Gynecology. I encourage you to look at that important document, 2017. So there's a lot of myths really in managing ovarian cysts in young girls. And I mean, the simple thing, you come and see a young girl come to your clinic and think, I was told I have a cyst. And you can see the anxiety and fear in her face. So what you need to reassure her about that? You need to reassure her that it is very common. Majority of them are benign, self-resolving. Less than 10% of these cysts are malignant. Ovarian malignant tumors account for only 1% of childhood and adolescent cancer. So this is a fact. I'm sure you are aware about the complex cysts, which could be a benign endometrioma cyst with cyclical pelvic pain, and there is a benign one which is mature cystic teratoma, or what we call it a dermoid cyst. The malignant tend to be germ cell tumor, dysgerminoma, endodermal sinus tumors, and embryonal carcinoma, and lastly is choriocarcinoma, which could be associated with rising HCG. The traditional approach for ovarian cysts, simple one, is size less than 5 centimeters. I would like to reassure you there is nothing to worry about. This will resolve. 5 to 7 centimeter cyst, recommendation for the Royal College is annual follow-up. I'm sure most of you, they won't do annual follow-up for a 6 centimeter cyst. And girls would like to have more reassurance by another scan, maybe in 3 or 4 months' time. Simple cyst more than 7 centimeters, consider intervention here with either do an MRI prior to that or offer surgery due to the size and the pressure symptoms. Now, complex cyst, you need to have further elaboration on tumor markers, which, as you can see here, LDH-CA125, alpha-fetoprotein. This is a flow chart, a little bit busy, but actually summarize what I just said. Is if there is suspicion of torsion or pain, this is a different method. Go to the acute service. If there are no symptoms, depend on the size and consistency. Simple cyst, as we discussed. Complex cyst, follow the pathway, doing a tumor markers, and refer to pediatric gynecology service. Now, if you decide to operate, the recommendation is try to go for a minimum access laparoscopic surgery, adequate preoperative counseling about the risks, reduce risk of ovarian reserve and the future subfertility. Please try to highlight these important issues and aim for conservative surgery. I highlighted that there is no role of radical surgery in young girls, especially oophorectomy. Please retain as much as ovarian tissue as you can and try to use adhesion prevention methods that you have. This is a short video clip of a simple ovarian cyst I did. As you can see, this is the left ovary is normal, the right ovary have a large cyst in it, simple cyst causing pain. So what we usually do, as you can see prior to that, is we incise the capsule of the cyst with diathermy and then try to peel the cyst off the ovarian tissue. And as you can see, traction, counterpart traction here, and try to remove the cyst only and conserving as much as ovarian tissue as you can. And slowly we peel the cyst off the ovarian tissue, aiming to be as conservative as much as you can. This is the cyst peeled off the ovary itself. And then the two schools of suture or not to suture. I tend to await for hemostasis. And then if there is need for hemostasis, I use minimum bipolar diathermy, and occasionally I suture. So this is the cyst removed. And as you can see, there is adequate amount of ovarian tissue left. And this time I decided to suture the ovary. And I suture the ovary, as you can see, for better hemostasis. And then at the end, I leave a hyaluronic gel. This is a gel to reduce post-operative adhesions. You will be surprised about the good outcome and minimum adhesions after that. So the effect of pelvic surgery in ovarian reserve, as you can see in red here, salpingectomy has minimum effect on ovarian reserve, cystectomy a little bit and more effect. However, when you have endometrioma, significant effect on ovarian reserve. And obviously with oophorectomy, you're removing one ovary, so there is a reduction of ovarian reserve. One of the acute complications is ovarian torsion. Torsion is a complete or partial rotation of the ovary on its ligament. Obviously, the important thing is the blood supply will be affected, and occasionally the fallopian tube will be torted as well. This is a torsion of the tube and the ovary comparing with the normal side. Laboratory evaluation, obviously with any pelvic pain, rule out ectopic pregnancy, use your blood test, white cell count, pelvic ultrasound scan with Doppler, and definite diagnosis of torsion is by surgery when you see it on laparoscopy. This is a paper we published on laparoscopic management of fallopian tube torsion with a paratubal cyst. So not always the ovary, occasionally paratubal cyst can tort around itself. That was managed laparoscopically in adolescent young girl. The message to you is don't immediately remove the ovary. Try always to save the ovary by untwisting the ovary and draining any cyst. And consultant with relative expertise need to be involved. Even if the ovary appear black and necrotic, in most cases, the ovary usually recover, result in functional ovarian tissue. So cystectomy would be difficult in this situation due to the fragile tissue and can be carried out in an interval procedure if required. Oophorepraxy, which is suspension of the ovary, is controversial, and we don't have a lot of evidence on the long-term outcome. So this is a busy slide. I apologize for it, for management of pain in a young adolescent girl. As you can see here, depend on your investigation. Is it ovarian torsion? Manage it with surgery. Is it ectopic based on the HCG? Is the patient have discharge and fever? Could be a PID. Is it a mid-cycle pain, chronic? Could be metaleshmers, only simple analgesia. Is it recurrent pain, only dysmenorrhea? Or is it woman or young girl with no period amenorrhea? It could be imperforated hymen. So this is a case study of a 13-year-old girl, came with 5 days history of worsening lower abdominal pain. And she had a significant pain. She had an appendectomy followed by tubo-ovarian abscess. This is the image of tubo-ovarian abscess following the, this is a large tubo-ovarian abscess following the appendectomy. We decided what to do here. We don't want to take her to theater after a midline laparotomy. Is there any chance for a minimum intervention approach for her? Then we obviously give her IV antibiotic. We were worried about her future fertility, so we discussed it with our radiology colleague, and he did ultrasound-guided pelvic drainage, removed 200 ml of pus, continue on the antibiotics. It was negative culture for TB, and she improved and discharged home. The other topic is endometriosis, is around 25 to 38% in adolescent girls. Adolescent refractory medical treatment usually consider endometriosis. Management to start with is simple analgesia. You consider the combined pills or progesterone intervention with whether IUS is suitable or not. GnRH analog has a role, pros and cons for it. Endometriosis surgery is try to leave it last resort. However, it can be for women who are refractory to medical treatment. This slide will tell you about the effect of endometrioma on ovarian reserve, have different strategies on reducing ovarian reserve with oxidative stress, toxic contents, reduced follicular maturation. The shape of these lesions are different, could be white endometriosis, could be red endometriosis. The aim of surgery, excision of ovarian capsule, use of electrosurgery. Again, you will face with the dilemma of reduced ovarian reserve. Ovarian reserve, the presence of endometrioma associated with decreased ovarian reserve, even without surgery. So there are some evidence that AMH level will be reduced even within 6 months after ovarian surgery. The other complex issue with young girl is chronic pelvic pain, which could be many causes like any other woman, irritable bowel syndrome, musculoskeletal pain, interstitial cystitis. Recent study performed that cystoscopy and laparoscopy in 13-25 years of age girls, they found there are a total 25% were diagnosed with interstitial cystitis and endometriosis. Menorrhagia is dysfunctional bleeding in young girls, heavy and prolonged bleeding, occasionally can be associated with a clotting disorder. As you can see here, von Willebrand disease, 5 to 36%, platelet dysfunctions also there, clotting factor and thrombocytopenia could be a cause. Other causes of menorrhagia, including pregnancy complication and infection, sexually transmitted disease need to be ruled out, always medical options, no role of surgery in young girls. Now we covered a few minutes on genital tract injuries in young girls. It can be like any other woman, however, the soft tissue of the young girl is easy risk of tearing with a blunt penetrating trauma, and trampoline injury in the young girls coming to accident and emergency is quite common. Foreign body must be considered with young girl with persistent vaginal discharge and always offer anesthetic for its removal. There is a straddle injuries, most common accidental genitofemoral injuries with a vaginal trauma. The need for surgical intervention in pediatric genital trauma is low and should consider if vaginal bleeding cannot be ascertained. And always consider assault in similar circumstances and involve your pediatric colleagues. Vaginal tears or injuries can be after water jet injuries. When we go to water parks, forceful entry of the water into the vagina, need examination and anesthetic and suturing. Lastly, I would like to comment on female genital tract mutilation. Obviously, there is an international campaign to stop female circumcision and female genital tract circumcision. Surgery only recommended for women who have unable to have sex or difficulty in passing urine. Also, pregnant women, as a result of difficulty with labor, there is a role or de-infibulation. These are my references. In summary, most gynecological symptoms in adolescent girls can be treated conservatively. The gynecological problem encountered in adolescents are often both medically and psychologically complex, thus required highly skilled and coherent approach. When you decide on surgery, please involve most senior gynecologists. The other thing is surgery has a role in complicated ovarian cysts, refractory endometriosis, certain anomalies, and genital tract injuries. Thank you very much for your attention.
Any questions to Dr. Radwan Faraz? Any questions? Thank you, sir. Thank you very much for participation in this event.
No, my pleasure.
On behalf of Organizing Committee of Gynecology Conference, we want to thank you for insight presentation and looking forward to meet you again next time.
Thank you.
Thank you. Now we ask Dr. Vishwa Rao, Department of Obstetrics and Gynecology at Civil Hospital, India, to join this event and start presentation. Hello. Hello, Dr. Vishwa Rao. Please share your screen and start presentation. Actually, we are unable to, no voice. No voice is here. Please, madam, please check your audio settings. And please share your PPT. Start your presentation, madam. We have a lot of time, no problem. Speak properly. Hello, Dr. Vishwarao. Are you facing any technical problem? Otherwise, please share your PPT. We can play behalf of you. Okay, fine. Please unmute. Yes, unmute. Meanwhile, go with the other speaker. Please unmute, madam. Your voice. No, we have no voice coming. Madam, I think can you please check your audio settings? Okay, good. But I think you are operating through mobile, but it's the main issue. And open your video also, video settings, enable video settings. Sorry, to again, your voice is not coming. Okay, meanwhile, go with other speaker. Please, after one talk, you can present your talk. Please check, recheck your audio and video settings properly. Now we ask Dr. Trianto Ricardo, Department of Obstetrics and Gynecology, Asaduddin University, Indonesia, to join this event and start presentation.
Okay, sir. Thank you. Would you please share the PowerPoint?
Yes. Wait for 1 minute, sir. Okay, let's start.
Okay, thank you. I will present my research about relationship between estradiol levels and anxiety in postmenopausal women in our city in Makassar. As a background, menopause is a natural process that every woman experiences. These physiological changes from the reproductive phases to the non-reproductive phase is characterized by a gradual decrease in estrogen levels. Estradiol, which has the strongest estrogenic effect, makes up the bulk of estrogen. A woman will experience emotional instability along with anxiety about changes in the body due to the end of menstruation, which shows that women are very sensitive to emotional influences and hormonal fluctuations. As an objective to assess the relationship between levels of the hormone estradiol and anxiety levels in postmenopausal women. As a methods, we use the cross-sectional study conducted at 76 postmenopausal women with a history of menstrual cessation for more than 12 months. Estrogen level examination was performed on 5 cc of venous blood using ELISA methods. Anxiety level we assess using the self-rating anxiety scale. I present the result as in table as we see. And as a conclusion, one, estrogen levels did not affect the anxiety levels of postmenopausal women. Age, body mass index, estradiol levels, parity, marital status, and history of disease did not cause anxiety in postmenopausal women. On the other hand, the woman occupation factors influences postmenopausal woman anxiety. This my conclusion as my research that we did in our city in Makassar, and we hope the result can help us, especially in postmenopausal women, to not anxiety in low decrease of the estradiol levels. Thank you.
Thank you. Any questions? Any questions to Dr. Ricardo? Okay. Thank you, sir. Thank you for participation in this event. And on behalf of Organizing Committee of Gynecology Conference, we want to thank you for insight presentation. Looking forward to meet you again next time. Thank you. Now we ask Dr. Vishwarao. Department of Obstetrics and Gynecology at Civil Hospital, Ahmedabad, India. Hello, doctor. Please share your PPT to start your presentation. Yes. And unmute yourself. Please unmute. Hello, madam. Can you hear me? if you have facing any issues, please text me in chat box. Hello, doctor. Adibu. Hello, Doctor Vishwa. Sorry, madam. Still, we are not receiving your voice. I think, please, if possible, please operate laptop or system. I think mobile, some maybe mobile issue or PPT is shared successfully, but voice is not coming. Okay. Okay, yes, some Dr. Vishwarao facing some technical issues, so she will be joining after few minutes. Meanwhile, can I go with other speaker? Uh, we can ask Dr. Naini Fajra, Department of Obstetrics and Gynecology, Faculty of Medicine, Asaduddin University, Indonesia, to join this event and start the presentation, madam.
Good evening, everyone. The honorable audiences. My name is Naini Fajria. I am from Hasanuddin University, Makassar, Indonesia. First of all, I want to ask permission to share the recorded version of my presentation due to limited signal in here. The title of our study is Placental Toll-like receptor 7 expression associated with maternal HPV DNA, a potential transmission of hepatitis B virus from mother to child. Hepatitis B virus infection is a serious public health problem where more than 1 million people die every year due to this disease. The prevalence of HBV in pregnant women worldwide is around 5% and varies from 0.6% in low prevalence areas to more than 20% in high incidence areas in Eastern and African regions. Placenta is considered as a specific pregnancy component of the innate immune system and contain both mechanical and immunological barriers that restrict entry to the fetus. TLR is a type 1 transmembrane protein with extracellular leucine-rich domains capable of recognizing three types of ligands, which are nucleic acids, proteins, and lipids. From the study of Tian et al., revealed the function of placental trophoblasts as macrophages in recognizing and responding to pathogen through toll-like receptor expressions, and primary placental trophoblasts is more resistant to viral infection than non-trophoblastic cells. The mechanism by which placental trophoblasts combat viruses, including HBV, needs to be elucidated further. However, toll-like receptors on trophoblasts can play an important role. In this study, we assessed the role of toll-like receptor 7 in hepatitis B transmission by identifying maternal hepatitis B serum markers. For our methods, we have cross-sectional study design, and the study is conducted in 4 hospitals in Makassar from September 2019 to March 2020. Our population is all pregnant women with HBs antigen positive in Makassar. In the study, the inclusion criteria were pregnant women at term of gestation, infected with hepatitis B virus with positive HBs antigen test result, and the one that had never received antiviral therapy before. The exclusion criteria in the study were getting antiviral therapy for less than the last 6 months, receiving interferon therapy, pregnancy complication, fetal distress, autoimmune disease, HIV, syphilis, other infectious diseases, and the one with abnormal liver and kidney functions, and those who resigned for some reasons. The sample was taken by using purposive sampling technique. The number of samples in this study were 38 subjects. Relationship between placental toll-like receptor 7 expression and maternal HBV DNA was analyzed using the Fisher-Exact test. For our work procedures, we perform history taking, physical examination, and laboratory tests, which are HBs antigen and HBV DNA, to all participants who meet the criteria. A blood sample is taken later centrifuge after standing for at least 30 minutes at room temperature. Examination of HBs antigen markers were performed using ELISA, and the amount of HBV DNA was calculated using real-time quantitative PCR. Sample of the placenta in the form of cotyledons was taken to be tested for toll-like receptor 7 expression using the method immunohistochemistry. As the result, the study involved 38 hepatitis B pregnancy based on history, physical examination, and confirmed by laboratory examination. Sample characteristics divided according to age, parity, gestational age, and risk factor for hepatitis, including history of hepatitis and family history of hepatitis. You can see in table 1 that we divided our sample into 5 age groups. The first one is less than 20 years, the second one is 21 until 25 years, the third group is 26 until 30 years, the fourth group 31 until 35 years, and the last group is more than 35 years. 26 until 30 years, which is 42.1%, and only one sample in the age of less than 20 years, which is 2.6%. The youngest patients, age 18 years, and the oldest one is 39 years, with mean plus minus standard deviation 28.78 plus minus 4.7 years. More than half, 0.6%, and 2 samples were multi-parity. About 34.2% of our sample family history of hepatitis, which you can see in table 1. From table 2, you can see that in this study, we found that all samples with HBV DNA were maternal positive has a positive toll-like receptor 7. Meanwhile, all samples that are not expressing toll-like receptor 7 was found to have negative maternal HBV DNA. We also found no significant association between maternal HPV DNA and toll-like receptor 7X. As the discussion, toll-like receptors have an important role in recognizing and triggering the appropriate immune response against viral infections, including hepatitis B. It has been reported that toll-like HPV replication in vivo and in vitro, and Isogawa et al. Demonstrated a significant effect of toll-like receptor 7 expression on HPV virus replication. Toll-like receptor 3, toll-like receptor 4, toll-like receptor 5, toll-like receptor 7, and toll-like receptor 9 all modulate replication against hepatitis B virus. In this study, it was found that there was a significant correlation between HPV DNA titer with more than 200,000 international units per milliliter and the expression of toll-like receptor 7 levels that can be seen in Table 2. This is in line with the research conducted by Tian et al., where the expression of placental toll-like receptor 7 and toll-like receptor 8 was markedly increased in HPV DNA positive women. Significant results in this study occurred because of the immune response to HPV by the placental trophoblast, which is of HPV through upregulation of toll-like receptor 7 as an immune response to HPV infection. HPV DNA with more than 2 times 100,000 has a high risk of intrauterine true positive expression of toll-like receptor 7 on the placenta. The same study conducted by Gao et al. Revealed that there was a significant relationship between toll-like receptor 9 and toll-like receptor 3 expression and the risk of intrauterine infection. Gao et al. Describes the influence of the gene's role in the risk of vertical transmission and its relationship with the expression of toll-like receptor 3 and toll-like receptor 9, and required a large number of samples to determine the mechanisms of toll-like receptor expression and its relationship with intrauterine transmission. This study has several limitations, which are there is no analysis related to genetic factors from the mother, considering that genetic factors play a role in the immune response mechanism and its relation to toll-like receptor 7 expression. This study also didn't take HPV DNA or HBs antigen from infant samples to determine the risk of vertical transmission, and didn't follow up on infants whose mother had a high risk of HPV exposure. As our conclusion in this study, we found there is a significant association between toll-like and maternal HPV DNA. Therefore, toll-like receptor 7 is a potential transmission of hepatitis B virus from the mother to child.
Thank you. Thank you, Dr. Naini. Any questions? Any questions? Thank you very much, madam, for participation in this event. On behalf of Organizing Committee of Gynecology Conference, we want to thank you for insight presentation. We looking forward to meet you again next time. Hello.
Hello.
Now we request to present Dr. Vishwarao to join this event and share your presentation.
Hello. Am I audible? Hello.
Yes, madam. Yes.
Am I audible?
Yes. Yes.
Okay.
Yes. Yes. last talk of this today, last of, talk of this conference.
Can you see the presentation?
Yes, ma'am.
Okay. So today I'm going to present my study on sexuality in middle-aged females. A woman's sexual function, it changes over the course of her lifetime. There are a multitude of reasons for this change, including physical changes, relationship changes, acquiring diseases that accompany aging, behavioral changes, and the sexual capacity of the partner. Perimenopause represents a unique time period during which a woman goes through a number of life changes and often has a shift in concerns about her sexual health. Whereas younger women tend to report concerns about family planning, sexuality, and body image, middle-aged women tend to be preoccupied with their lack of sexual interest, sexual aversion, and difficulty with orgasm. However, even with these concerns, 15 to 60% of the postmenopausal women remain interested in sex. One of the most obvious changes that occur during perimenopause is a drastic decrease in the serum estrogen level. Estrogen is vital for maintaining the tissues related to sexual health. Women with prolonged estrogen deficiency have difficulty with vaginal and genital atrophy, clitoral shrinkage, and decreased sensation. Female sexual dysfunction, it affects about 50% of the postmenopausal women. Unfortunately, it often goes undiagnosed because both the patient and the healthcare providers may be reluctant to bring it up during regular office visits. Despite the increase in senior citizens percentage, little is known about the sexuality of women past the age of 40. The aim and the objective of the following study is to assess the sexual function and desire among middle-aged females and to assess age-related changes in the sexuality of middle-aged females. It was a cross-sectional study which was carried out in Obstetrics and Gynecology department at Civil Hospital, Ahmedabad, involving 50 middle-aged females in the age group of 30 to 55 years. Oral and informed consent was taken. A female sexual function index performer was used to interview the patients. Female Sexual Functioning Index is a brief multidimensional scale which was used for assessing sexual function in women. The questionnaire, it consists of 19 questions covering 6 domains. The domains are the desire domain, having 2 questions, the arousal domain, and the lubrication domain, having 4 questions each, the orgasm domain, the satisfaction domain, and the pain domain, having 3 questions each. High score, it indicates better sexual function. Response to each question are scored either from 0, that is no sexual activity, or 1, which is indicative of dysfunction, to 5, which is suggestive of normal sexual activity. Individual domain scores are obtained by adding the scores of the individual questions that comprise a domain and multiplying the sum by the domain factor provided in the FSFI for each domain. The full-scale score is obtained by adding the 6 domain score. The minimal score possible is 2 and maximum is 36. The cutoff score to demarcate sexual dysfunction is 26.55 as obtained from a validation study. The inclusion criteria for the study was middle-aged females in the age group of 30 to 55 years, females engaged in regular sexual activity, and the exclusion criteria for the study was individuals refusing to cooperate, individuals not engaged in sexual activity in last 6 months, or those not residing with their partner. The results of the study was there is an increase in the prevalence of female sexual dysfunction and decrease in the sexuality with increase in age amongst women. The female sexual dysfunction was considered if FSFI score is less than 26.55. Here in this study, in the age group of 30 to 39, it was found that 3 females were found to have female sexual dysfunction. In the age group of 40 to 49, it was found that 20 females were found to have female sexual dysfunction. And in the age group of 50 to 55, 8 females were found to have female sexual dysfunction out of the total female 50 females who were taken in the study. Dividing the same female sexual dysfunction among the perimenopausal, premenopausal, and the menopausal females, it was found that the prevalence of female sexual dysfunction was increasing in the menopausal female. In premenopausal female, it was found that the female sexual dysfunction was prevalent in 4 individuals. In perimenopausal females, it was found that the female sexual dysfunction was prevalent in 8 females. And in the menopausal age group, it was found that the female sexual dysfunction was prevalent into 18 females. This chart, it represents the types of the female sexual dysfunction and its prevalence. The most common type of the female sexual dysfunction was found to be the arousal dysfunction, which was prevalent in 35% of the patients. The second most common sexual dysfunction, which was found in females, was the desire dysfunction, which was prevalent in 22.6% of the females. The third most common dysfunction which was found was pain sexual dysfunction, which was prevalent in amongst almost 16.1% of the females. The fourth most common sexual dysfunction was satisfaction dysfunction, which was present in 12.9% of the females. The others were orgasm dysfunction and lubrication dysfunction, which were present in 9.7% and 3.2% of the females, respectively. The sexual response, the sexual desire, and the frequency of sexual intercourse in women have decreased with age, leading to the sexual dysfunction in women. There is a significant reduction in sexual function of postmenopausal women. Menopause is associated with anatomical, physiological, and psychological changes that often influence sexuality in aging women. Decreased estrogen levels have a multitude of effects on the sexual function, including loss of the ability to lubricate the urogenital tissues adequately and changes in the body configuration. This situation is aggravated by alterations in the skin, breast, muscles, and the skeleton caused by estrogen loss. For many women, these changes translate into a poorer self-image, diminution of self-esteem, and eventually a loss of sexual desire. Few studies have shown that female sexual function is reduced by increasing educational level. The sexual desire in females had a significant association with diabetes, hypertension, heart disease, high cholesterol levels, chronic pain, gastrointestinal problems, chronic ulcers, bladder and intestinal problems, and joint and bone disorders, which is indicative that sexual desire decreases with any of the present comorbidities in the females. Repetitive dyspareunia caused by vaginal dryness represents a sexual problem for women and can lead to a lack of arousal and inability to achieve orgasm and loss of sexual desire. This situation may end up with women avoiding all the sexual activities. Societal expectations also have a negative impact on sexuality, as most cultures still believe that older women should become sexually retired. Compared with men, women at all ages were significantly less likely to report sexual activity. Aging affected female sexuality negatively. There was a decrease in the frequency of intercourse, the frequency of unprovoked desire, and the ability to obtain vaginal lubrication. It is found that the frequency of dyspareunia it increases in the postmenopausal women, which may be most likely due to loss of estrogen. The overall satisfaction with the sexual life was found to be decreasing with age. These are the references for the study. Thank you.
Thank you. Thank you very much, madam. Any questions to Dr. Vishwarao? Any questions? Thank you very much.
Okay,
thank you very much, madam, for participation in this event. And on behalf of Organizing Committee of Gynecology Conference, we want to thank you for insight presentation. And looking forward to meet you again next time.
Sure, thank you.
Thank you very much, madam. And thank you very much to all the participants, those who joined the webinar gynecology event during this period, having different time zones. Our most sincere thanks to all keynote speakers, plenary speakers, students, delegates, journal collaborators, media partners, who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitation to participate in this conference. We have received several papers which will form the basis of our discussion in the various sessions. Let us thank you all for associating with this conference by your presence. A special thanks to Dr. Program Manager, Mr. Henry Bruce, for his continuous effort in putting us all together under one platform in this online event. Keynote lectures from Haitham Al-Sam Dr. Jakob Matai, and Dr. Hangwei Ling. And speakers, they are presenting valuable and informative presentations, and we hope this conference is very helpful to all participants. And special thanks to Dr. Bhagyasri, Adeline Uraik, Dr. Priyanka, Dr. Radwan Faraz, Dr. Devi Nobita, Dr. Naini Fajre, Dr. Vishwarao, and we will send official through mail, e-certificate and e-book shortly. If everything goes well in 2021, hope will join in physical event, same topic, gynecology conference in Dubai or any other continent. Thank you very much for the opportunity to take part in the conference. On behalf of the organizing committee of Inovine conferences, I want to thank you for insightful presentation of today. Your message was exactly what we needed to hear. Thank you very much for unforgettable support to our organization. We will send shortly, we will send within 2 days, we will send ebook and e-certificate to your mentioned mail ID. If you have any queries or comments, please send me my organization mail ID and WhatsApp number. We will send your queries to answers shortly, and we will send our conference committee members and our team members next conference invitations shared to everyone shortly, and we will invite all distinguished guests, speakers around the world. Next time, definitely we'll participate physical event, not an online event. We are expecting, and I hope everything goes well. Thank you for supporting Asaduddin University Indonesia people. They're participating 5 members in this conference. They are supporting unforgettable support. And thanks to everyone. This is signing off. This is Ramakrishna signing off. Have a great day. Thank you. And one more thing, last Dr. Naini Faraz, some I think topic completed or disconnect your system disconnected. I think conference your topic is completed. If you have any queries or any comments, please send me. We will forward to my committee members, and we will improve my conference schedule and conference type. And your papers will be published in international journal within 1 or 2 months. Thank you.